Tes, tes. Tes 1, 2. Oke.
Dalam upaya peningkatan kualitas sumber daya manusia di dunia pendidikan, penguasaan bahasa asing, dalam hal ini bahasa Jerman, merupakan suatu hal yang sangat penting bagi Poltekkes Kemenkes Medan, khususnya Prodi D3 Keperawatan Dairi.
Guten Tag, hallo alle zusammen. Ich heiße Jojo Silaban. Ich bin Lauter des Studiengangs auf dem Krankenpflegerfachschule Dairi. Prodi D3 Keperawatan Dairi menyelenggarakan pendidikan tenaga keperawatan yang merupakan tenaga kesehatan yang paling banyak diminati secara internasional. Untuk menciptakan lulusan yang berdaya saing global, Prodi D3 Keperawatan Dairi memperlengkapi lulusannya dengan kemampuan berbahasa Jerman dengan upaya yang kami sebut Jerman Camp atau Deutsche Woche. Dankeschön, vielen Dank.
Prodi D3 Keperawatan Dairi melaksanakan Jerman Camp dengan kegiatan seperti melaksanakan intensif les bahasa dengan instruktur tinggal di asrama Prodi D3 Keperawatan Dairi dan hidup bersama sehari-hari dengan mahasiswa selama pelaksanaan kursus atau les.
Guten Morgen alle zusammen.
Guten Morgen, Frau.
Ich heiße Christiana Melinda Neibahu.
Ich bin Dozentin auf dem Kinderkrankenpflege. Bitten Instruktur.
Membudayakan penggunaan bahasa Jerman bagi seluruh sivitas prodi dengan cara menggunakan salam atau sapaan dalam bahasa Jerman.
Wie kann ich Ihnen helfen? Ja, kannst du bitte diese Bücher Büro mitbringen?
Natürlich, Frau.
Vielen Dank.
Bitte schön, Frau.
Penggunaan bahasa Jerman dalam kegiatan laboratorium khususnya penciri prodi keperawatan gawat darurat. Memberlakukan 1 hari berbahasa Jerman di setiap hari Rabu yang disebut dengan Am Mittwoch of Deutsch Bitte. Memberikan livet dalam bahasa Jerman berisi mengucapkan salam dan perkenalan diri.
Halo, guten Morgen, Frau.
menciptakan atmosfer Jerman di lingkungan kampus dan asrama Prodi D3 Keperawatan Dairi dengan cara menempatkan spanduk besar dalam bahasa Jerman berisikan ucapan selamat datang di Prodi D3 Keperawatan Dairi, membuat name tag setiap ruangan kantor dan asrama dalam bahasa Jerman, melaksanakan permainan-permainan berbahasa Jerman, menghafalkan lagu-lagu berbahasa Jerman, penggunaan bahasa Jerman dalam beraktivitas hingga malam hari ketika tidur dan ibadah. Rencana Prodi D3 Keperawatan Dairi ke depan adalah melaksanakan Jerman Tour setelah 50% pelaksanaan intensif kursus atau les untuk mengevaluasi penguasaan bahasa serta meningkatkan perbendaharaan kosakata. Pelaksanaan evaluasi kemampuan berbahasa Jerman di akhir kegiatan. Jayalah Prodi D3 Keperawatan Dairi. Politeknik Kesehatan Kementerian Kesehatan Medan terletak di Kota Medan. Medan merupakan ibu kota Provinsi Sumatera Utara, kota terbesar ketiga di Indonesia dengan penduduk lebih dari 2 juta jiwa. Politeknik Kesehatan Kementerian Kesehatan Medan sebagai satuan kerja Badan Layanan Umum yang berada di bawah Direktorat Jenderal Tenaga Kesehatan Kementerian Kesehatan Republik Indonesia. Lokasi Direktorat Politeknik Kesehatan Kementerian Kesehatan Medan terletak di Jalan Lejen Jamin Ginting, kilometer 13,5, Kelurahan Lauci, Kecamatan Medan Tuntungan, Sumatera Utara. Visi Politeknik Kesehatan Kementerian Kesehatan Medan menjadi institusi yang unggul dan kompetitif dalam menyediakan tenaga kesehatan di tingkat nasional dan siap bersaing di tingkat internasional tahun 2024. Misi Politeknik Kesehatan Kementerian Kesehatan Medan menyelenggarakan Tridharma Perguruan Tinggi yang kompetitif mengikuti perkembangan iptek, mempersiapkan SDM di bidang kesehatan yang profesional, bermoral, beretika, dan siap bersaing di tingkat nasional dan internasional, memperkuat jejaring dengan pemerintah maupun swasta tingkat nasional dan internasional.
Poltekkes Kemenkes Medan merupakan salah satu unit pelaksana teknis di bawah Kementerian Kesehatan yang berada di bawah Direktorat Jenderal Tenaga Kesehatan. Poltekkes Kemenkes Medan menjalankan fungsinya yaitu menghasilkan tenaga kesehatan yang profesional dengan melaksanakan Tridharma Perguruan Tinggi meliputi pendidikan, pengajaran, penelitian, dan pengabdian masyarakat. Secara administrasi, Poltekkes Kemenkes Medan dibina oleh Direktorat Jenderal Tenaga Kesehatan, secara teknis dibina oleh Kementerian Pendidikan dan Kebudayaan, dan secara tata kelola keuangan BLU dibina oleh Kementerian Keuangan.
Politeknik Kesehatan Kementerian Kesehatan Medan telah terakreditasi B oleh BAN PT dengan nomor SK 122-SK-BAN PT-AKRED-PT-6 2018. Terdiri dari 19 program studi. Program Diploma 3 meliputi Farmasi, Kesehatan Gigi, Teknologi Laboratorium Medis, Keperawatan Medan, Keperawatan Gunung Sitoli, Keperawatan Tapanuli Tengah, Keperawatan Dairi, Kebidanan Medan, Kebidanan Pematang Siantar, Kebidanan Tarutung, Kebidanan Padang Sidempuan, Gizi, Sanitasi, Program Sarjana Terapan Kesehatan meliputi keperawatan, kebidanan, sanitasi lingkungan, gizi dan dietetika, pendidikan program profesi bidan, pendidikan program profesi nurse, penambahan program studi lain di bidang kesehatan terus diupayakan.
Saya melaksanakan tugas direktur dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat sehingga menghasilkan lulusan yang kompeten dalam bidang kesehatan yang mampu mendukung transformasi kesehatan di Indonesia.
Saya melaksanakan tugas direktur dalam bidang administrasi umum, keuangan, dan kepegawaian. Di bidang keuangan, anggaran yang ada terdiri dari rupiah murni dan dari BLU atau Badan Layanan Umum.
Saya melaksanakan tugas direktur dalam bidang kemahasiswaan, alumni, dan kerjasama. Untuk bidang kemahasiswaan dan alumni, kita memberikan pelayanan kepada mahasiswa mulai dari proses penerimaan mahasiswa baru sampai dengan wisuda, dan termasuk untuk alumni dalam hal pendayagunaan lulusan Poltekkes Kemenkes Medan. Untuk bidang kerjasama, kita melaksanakan MOU dan MOA baik untuk instansi dalam negeri maupun luar negeri, dan juga bekerja sama dengan BEM dan UKM dalam pelaksanaan kegiatan di kampus, termasuk berpartisipasi untuk di event-event nasional dan internasional.
Dalam rangka menunjang kegiatan pembelajaran teori dan praktik, Poltekkes Kemenkes Medan didukung fasilitas seperti asrama, laboratorium terpadu dan jurusan, laboratorium komputer dan ruang CBT, laboratorium bahasa dan mini teater, perpustakaan terpadu dan jurusan, auditorium, klinik atau balai pengobatan, musola, bus dan mobil ambulans, sehingga lulusan Politeknik Kesehatan Kementerian Kesehatan Medan siap kerja dalam bidang kesehatan. Moto Politeknik Kesehatan Kementerian Kesehatan Medan, Smart, Santun, Mahir, Andalan, Ramah, Tanggung Jawab. Mari bergabung dengan Politeknik Kesehatan Kementerian Kesehatan Medan. Sehat tanpa korupsi, jaga diri, jaga teman, jaga Poltekkes Med, jaga Kementerian Kesehatan.
Medan Health Polytechnic of Ministry of Health is one of appointed health polytechnic as a pilot project for international class development. It is hoped that this class will excellent competitive and professional international class, especially for nursing class, and it will be pioneer for other departments that was already available in health polytechnic. Learning process in every subject of lectures designed to achieve graduate learning outcomes and interpreted with adaptive, communicative, creative, and innovative learning method.
Pengembangan kelas internasional Januari hingga Juli 2022. Tes TOEFL bagi dosen RKI jurusan keperawatan. Kursus bahasa Inggris bagi dosen keperawatan 2 kali seminggu. Mei hingga Juli 2022. Review kurikulum KI di Bekasi. Pembuatan RPS dalam bahasa Inggris. Sosialisasi RKI. Rekrutmen mahasiswa reguler RKI 17 orang. Agustus hingga Oktober 2022. English Day setiap Jumat. Workshop kurikulum RKI Prodi. November-Desember 2022. Berdasarkan SK nomor HK02.02.4-2-6190-2021 dan SK nomor HK.02.F.3-1463-2023. Benchmark ke KI Fakultas Keperawatan Universitas Hasanuddin Makassar. Test of English as a Foreign Language Institutional Testing Program Maret hingga Juni 2023. Koordinasi dan audiensi terkait pengembangan kelas internasional. Mengikuti English Camp dan modul Camp di Poltekkes Salaman. FGD Workshop Kurikulum KI 15 hingga 17 Juni 2023. Sosialisasi untuk penjaringan calon mahasiswa. Rekrutmen mahasiswa baru. Juli hingga Agustus 2023. Placement test bagi dosen yang akan mengikuti kursus bahasa Inggris dalam rangka TOEFL Preparation. Evaluasi kurikulum kelas internasional. English Camp for Lecture. Tes TOEFL. Perkuliahan semester ganjil KI tahun ajaran 2023-2024. September 2023. Renovasi Classroom KI dengan desain Dynamic Class. Renovasi Laboratorium Bahasa berstandar internasional. Pengembangan aplikasi pembelajaran LMED. Penyediaan akun kelas internasional pada aplikasi SIAKAD. Penyelesaian Academic Guideline. Oktober 2023. Workshop Public Speaking dan Service Excellent. Seminar Internasional. Penyelesaian renovasi classroom dan lab bahasa. Launching kelas internasional keperawatan. November-Desember 2023. Monitoring dan evaluasi kegiatan PBM kelas internasional. Monitoring dan evaluasi kegiatan English Day di kampus dan asrama. Dalam upaya peningkatan kualitas sumber daya manusia di dunia pendidikan, penguasaan bahasa asing, dalam hal ini bahasa Jerman, merupakan suatu hal yang sangat penting bagi Poltekkes Kemenkes Medan, khususnya Prodi D3 Keperawatan Dairi.
Guten Tag, hallo alle zusammen. Ich heiße Jojo Silaban. Ich bin Lauter des Studiengangs auf dem Krankenpflegerfachschule Dairi. Prodi D3 Keperawatan Dairi menyelenggarakan pendidikan tenaga keperawatan yang merupakan tenaga kesehatan yang paling banyak diminati secara internasional. Untuk menciptakan lulusan yang berdaya saing global, Prodi D3 Keperawatan Dairi memperlengkapi lulusannya dengan kemampuan berbahasa Jerman dengan upaya yang kami sebut Jerman Camp atau Deutsche Woche. Dankeschön, vielen Dank.
Prodi D3 Keperawatan Dairi melaksanakan Jerman Camp dengan kegiatan seperti melaksanakan intensif les bahasa dengan instruktur tinggal di asrama Prodi D3 Keperawatan Dairi dan hidup bersama sehari-hari dengan mahasiswa selama pelaksanaan kursus atau les.
Guten Morgen alle zusammen. Ich heiße Medan.
Ich bin Dozentin auf dem Kinderkrankenpflege. Bitten Instruktur.
Membudayakan penggunaan bahasa Jerman bagi seluruh sivitas prodi dengan cara menggunakan salam atau sapaan dalam bahasa Jerman.
Wie kann ich Ihnen helfen?
Ja, kannst du bitte diese Bücher kam Euro mitbringen?
Natürlich, Frau.
Vielen Dank.
Bitteschön, Frau.
Penggunaan bahasa Jerman dalam kegiatan laboratorium khususnya penciri prodi keperawatan gawat darurat. Memberlakukan 1 hari berbahasa Jerman di setiap hari Rabu yang disebut dengan Am Mittwoch of Deutsch Bitte. Memberikan livet dalam bahasa Jerman berisi mengucapkan salam dan perkenalan diri.
Hallo, guten Morgen, Frau. Ich bin Gracia Berbeda Berbangun. Ich wohne in Sidikalang. Ich komme aus Kemenkes.
Menciptakan atmosfer Jerman di lingkungan kampus dan asrama Prodi D3 Keperawatan Dairi dengan cara menempatkan spanduk besar dalam bahasa Jerman berisikan ucapan selamat datang di Prodi D3 Keperawatan Dairi, membuat name tag setiap ruangan kantor dan asrama dalam bahasa Jerman. Melaksanakan permainan-permainan berbahasa Jerman. Menghafalkan lagu-lagu berbahasa Jerman. Penggunaan bahasa Jerman dalam beraktivitas hingga malam hari ketika tidur dan ibadah. Rencana Prodi D3 Keperawatan Dairi ke depan adalah melaksanakan Jerman Tour setelah 50% pelaksanaan intensif kursus atau les untuk mengevaluasi penguasaan bahasa serta meningkatkan perbendaharaan kosakata. Pelaksanaan evaluasi kemampuan berbahasa Jerman di akhir kegiatan. Jayalah Prodi D3 Keperawatan Dairi. Poltekkes Kesehatan Kementerian Kesehatan Medan terletak di Kota Medan. Medan merupakan ibu kota Provinsi Sumatera Utara, kota terbesar ketiga di Indonesia dengan penduduk lebih dari 2 juta jiwa. Poltekkes Kesehatan Kementerian Kesehatan Medan sebagai satuan kerja Badan Layanan Umum yang berada di bawah Direktorat Jenderal Tenaga Kesehatan Kementerian Kesehatan Republik Indonesia. Lokasi Direktorat Poltekkes Kesehatan Kementerian Kesehatan Medan terletak di Jalan Lejen Jaming Ginting, kilometer 13,5, Kelurahan Lauci, Kecamatan Medan Tuntungan, Sumatera Utara. Visi Poltekkes Kesehatan Kementerian Kesehatan Medan menjadi institusi yang unggul dan kompetitif dalam menyediakan tenaga kesehatan di tingkat nasional dan siap bersaing di tingkat internasional tahun 2024. Misi Poltekkes Kesehatan Kementerian Kesehatan Medan menyelenggarakan Tridharma Perguruan Tinggi yang kompetitif mengikuti perkembangan iptek, mempersiapkan SDM di bidang kesehatan yang profesional, bermoral, beretika, dan siap bersaing di tingkat nasional dan internasional, memperkuat jejaring dengan pemerintah maupun swasta tingkat nasional dan internasional.
Poltekkes Kemenkes Medan merupakan salah satu unit pelaksana teknis di bawah Kementerian Kesehatan yang berada di bawah Direktorat Jenderal Tenaga Kesehatan. Poltekkes Kemenkes Medan menjalankan fungsinya yaitu menghasilkan tenaga kesehatan yang profesional dengan melaksanakan Tridharma Perguruan Tinggi meliputi pendidikan, pengajaran, penelitian, dan pengabdian masyarakat. Secara administrasi, Poltekkes Kemenkes Medan dibina oleh Direktorat Jenderal Tenaga Kesehatan, secara teknis dibina oleh Kementerian Pendidikan dan Kebudayaan, dan secara tata kelola keuangan BLU dibina oleh Kementerian Keuangan.
Poltekkes Kesehatan Kementerian Kesehatan Medan telah terakreditasi B oleh BAN PT dengan nomor SK 122-SK-BAN PT-AKRED-PT-6 2018. Terdiri dari 19 program studi. Program Diploma 3 meliputi Farmasi, Kesehatan Gigi, Teknologi Laboratorium Medis, Keperawatan Medan, Keperawatan Gunung Sitoli, Keperawatan Tapanuli Tengah, Keperawatan Dairi, Kebidanan Medan, Kebidanan Pematang Siantar, Kebidanan Tarutung, Kebidanan Padang Sidempuan, Gizi, Sanitasi, Program Sarjana Terapan Kesehatan meliputi Keperawatan, Kebidanan, Sanitasi Lingkungan, Gizi dan Dietetika, Pendidikan Program Profesi Bidan, Pendidikan Program Profesi Nurse, penambahan program studi lain di bidang kesehatan terus diupayakan.
Saya melaksanakan tugas direktur dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat, sehingga menghasilkan lulusan yang kompeten dalam bidang kesehatan yang mampu mendukung transformasi kesehatan di Indonesia.
Saya melaksanakan tugas direktur dalam bidang administrasi umum, keuangan, dan kepegawaian. Di bidang keuangan, anggaran yang ada terdiri dari rupiah murni dan dari BLU atau Badan Layanan Umum.
Saya melaksanakan tugas direktur dalam bidang kemahasiswaan, alumni, dan kerjasama. Untuk bidang kemahasiswaan dan alumni, kita memberikan pelayanan kepada mahasiswa mulai dari proses penerimaan mahasiswa baru sampai dengan wisuda, dan termasuk untuk alumni dalam hal pendayagunaan lulusan Poltekkes Kemenkes Medan. Untuk bidang kerjasama, kita melaksanakan MOU dan MOA baik untuk instansi dalam negeri maupun luar negeri, dan juga bekerja sama dengan BEM dan UKM dalam pelaksanaan kegiatan di kampus, termasuk berpartisipasi untuk di event-event nasional dan internasional.
Dalam rangka menunjang kegiatan pembelajaran teori dan praktik, Poltekkes Kemenkes Medan didukung fasilitas seperti asrama, laboratorium terpadu dan jurusan, laboratorium komputer dan ruang CBT, laboratorium bahasa dan mini teater, perpustakaan terpadu dan jurusan, auditorium, klinik atau balai pengobatan, musola, bus dan mobil ambulans, sehingga lulusan Politeknik Kesehatan Kementerian Kesehatan Medan siap kerja dalam bidang kesehatan. Moto Politeknik Kesehatan Kementerian Kesehatan Medan: Smart, santun, mahir, andalan, ramah, tanggung jawab. Mari bergabung dengan Politeknik Kesehatan Kementerian Kesehatan Medan. Sehat tanpa korupsi, jaga diri, jaga teman, jaga Poltekkes Med, jaga Kementerian Kesehatan.
Medan Health Polytechnic of Ministry of Health is one of appointed health polytechnic as a pilot project for international class development. It is hoped that this class will excellent competitive and professional international class, especially for nursing class, and it will be pioneer for other departments that was already available in health polytechnic. Learning process in every subject of lectures designed to achieve graduates learning outcomes and interpreted with adaptive, communicative, creative, and innovative learning method.
Pengembangan kelas internasional Januari hingga Juli 2022. Tes TOEFL bagi dosen RKI jurusan keperawatan. Kursus bahasa Inggris bagi dosen keperawatan 2 kali seminggu. Mei hingga Juli 2022. Review kurikulum KI di Bekasi. Pembuatan RPS dalam bahasa Inggris. Sosialisasi RKI. Rekrutmen mahasiswa reguler RKI 17 orang. Agustus hingga Oktober 2022. English Day setiap Jumat. Workshop kurikulum RKI Prodi. November-Desember 2022. Berdasarkan SK nomor HK.02.04-2-6190-2021 dan SK nomor HK.02.03-F-3-1463-2023. Benchmark KKI Fakultas Keperawatan Universitas Hasanuddin Makassar. Test of English as a Foreign Language Institutional Testing Program Maret hingga Juni 2023. Koordinasi dan audiensi terkait pengembangan kelas internasional. Mengikuti English Camp dan modul Camp di Poltekkes Salaman. FGD Workshop Kurikulum KI 15 hingga 17 Juni 2023. Sosialisasi untuk penjaringan calon mahasiswa. Rekrutmen mahasiswa baru. Juli hingga Agustus 2023. Placement test bagi dosen yang akan mengikuti kursus bahasa Inggris dalam rangka TOEFL Preparation. Evaluasi kurikulum kelas internasional. English Camp for Lecture. Tes TOEFL. Perkuliahan semester ganjil KI tahun ajaran 2023-2024. September 2023. Renovasi Classroom KI dengan desain Dynamic Class. Renovasi Laboratorium Bahasa berstandar internasional. Pengembangan aplikasi pembelajaran LMED. Penyediaan akun kelas internasional pada aplikasi SIAKAD. Penyelesaian Academic Guideline. Oktober 2023. workshop public speaking dan service excellence, seminar internasional, penyelesaian renovasi classroom dan lab bahasa, launching kelas internasional keperawatan, November-Desember 2023, monitoring dan evaluasi kegiatan PBM kelas internasional, monitoring dan evaluasi kegiatan English Day di kampus dan asrama.
Medan Health Polytechnic of Ministry of Health, located in Medan City. Medan is the capital of North Sumatra Province, the third largest city in Indonesia, with a population of 2,460,858 people. Medan Health Polytechnic of Ministry of Health conveniently located on Jalan Lecen Jamin Ginting, 13.5 kilometers Lauchit Village, Medan Tuntungan Subdistrict, North Sumatra. Medan Health Polytechnic of Ministry of Health is a public service agency work unit under the Director General of Health Ministry of Indonesian Republic. The task of Medan Health Polytechnic of Ministry of Health is carried out of the education of health workers, which includes associated degree, applied and professional bachelor programs. Medan Health Polytechnic of Ministry of Health is one of 38 health polytechnics in Indonesia, formed in 2001 from several combined academies under the auspices of Ministry of Health. The vision of Medan Health Polytechnic of Ministry of Health is to become an excellent and competitive institutions providing health workers at the national level and ready to compete at international level in 2024. Let's join Medan Health Polytechnic of Ministry of Health, healthy without corruptions. Take of yourself, take of your friends, take of your Medan Health Polytechnic, and take care of Ministry of Health. Medan Health Polytechnic of Ministry of Health, located in Medan City. Medan is the capital of North Sumatra Province, the third largest city in Indonesia, with a population of 2,460,858 people. Medan Health Polytechnic of Ministry of Health conveniently located on Jalan Lecen Jamin Ginting, 13.5 kilometers Lauchit Village, Medan Tuntungan Subdistrict, North Sumatra. Medan Health Polytechnic of Ministry of Health is a public service agency work unit under the Director General of Health Ministry of Indonesian Republic. The task of Medan Health Polytechnic of Ministry of Health is carried out of the education of health workers, which includes associated degree, applied and professional bachelor programs. Medan Health Polytechnic of Ministry of Health is one of 38 health polytechnics in Indonesia, formed in 2001 from several combined academies under the auspices of Ministry of Health. The vision of Medan Health Polytechnic of Ministry of Health is to become an excellent and competitive institutions providing health workers at the national level and ready to compete at international level in 2024. Let's join Medan Health Polytechnic of Ministry of Health, healthy without corruptions. Take of yourself, take of your friends, take of your Medan Health Polytechnic, and take care of Ministry of Health. Medan Health Polytechnic of Ministry of Health, located in Medan City. Medan is the capital of North Sumatra Province, the third largest city in Indonesia, with a population of 2,460,858 people. Medan Health Polytechnic of Ministry of Health conveniently located on Jalan Lejen Jamin Ginting, 13.5 kilometers Lojit Village, Medan Tuntungan Subdistrict, North Sumatra. Medan Health Polytechnic of Ministry of Health is a public service agency work unit under the Directorate General of Health Ministry of Indonesian Republic. The task of Medan Health Polytechnic of Ministry of Health is carried out of the education of health workers, which includes associated degree, applied and professional bachelor programs. Medan Health Polytechnic of Ministry of Health is one of 38 health polytechnics in Indonesia, formed in 2001 from several combined academies under the auspices of Ministry of Health. The vision of Medan Health Polytechnic of Ministry of Health is to become an excellent and competitive institution, providing health workers at the national level and ready to compete at international level in 2024. Let's join Medan Health Polytechnic of Ministry of Health, healthy without corruptions. Take of yourself, take of your friends, take of your Medan Health Polytechnic, and take care of Ministry of Health. Medan Health Polytechnic of Ministry of Health, located in Medan City. Medan is the capital of North Sumatra Province, the third largest city in Indonesia, with a population of 2,460,858 people. Medan Health Polytechnic of Ministry of Health conveniently located on Jalan Lejen Jamin Ginting, 13.5 kilometers Lojit Village, Medan Tuntungan Subdistrict, North Sumatra. Medan Health Polytechnic of Ministry of Health is a public service agency work unit under the Directorate General of Health Ministry of Indonesian Republic. The task of Medan Health Polytechnic of Ministry of Health is carried out of the education of health workers, which includes associated degree, applied and professional bachelor programs. Medan Health Polytechnic of Ministry of Health is one of 38 health polytechnics in Indonesia, formed in 2001 from several combined academies under the auspices of Ministry of Health. The vision of Medan Health Polytechnic of Ministry of Health is to become an excellent and competitive institution, providing health workers at the national level and ready to compete at international level in 2024. Let's join Medan Health Polytechnic of Ministry of Health, healthy without corruptions. Take of yourself, take of your friends, take of your Medan Health.
Dalam upaya peningkatan kualitas sumber daya manusia di dunia pendidikan, penguasaan bahasa asing, dalam hal ini bahasa Jerman, merupakan suatu hal yang sangat penting bagi Poltekkes Kemenkes Medan, khususnya Prodi D3 Keperawatan Dairi.
Guten Tag, hallo alle zusammen. Ich heiße Jojo Silaban. Ich bin Lauter des Studiengangs auf dem Krankenpflegerfachschule Dairi. Prodi D3 Keperawatan Dairi menyelenggarakan pendidikan tenaga keperawatan yang merupakan tenaga kesehatan yang paling banyak diminati secara internasional. Untuk menciptakan lulusan yang berdaya saing global, Prodi D3 Keperawatan Dairy memperlengkapi lulusannya dengan kemampuan berbahasa Jerman dengan upaya yang kami sebut Jerman Camp atau Deutsche Woche. Dankeschön, vielen Dank.
Prodi D3 Keperawatan Dairy melaksanakan Jerman Camp dengan kegiatan seperti melaksanakan intensif les bahasa dengan instruktur tinggal di asrama Prodi D3 Keperawatan Dairy dan hidup bersama sehari-hari dengan mahasiswa selama pelaksanaan kursus atau les.
Guten Morgen alle zusammen. Guten Morgen, Frau. Ich heiße Christiana Melinda Neibahu.
Ich bin Dozentin auf dem Kinderkrankenpflege. Bitten Instruktur.
Membudayakan penggunaan bahasa Jerman bagi seluruh sivitas prodi dengan cara menggunakan salam atau sapaan dalam bahasa Jerman.
Wie kann ich Ihnen helfen?
Ja, kannst du bitte diese Bücher Euro mitbringen?
Natürlich, Frau.
Vielen Dank.
Bitte schön, Frau.
Penggunaan bahasa Jerman dalam kegiatan laboratorium khususnya penciri prodi keperawatan gawat darurat. Memberlakukan 1 hari berbahasa Jerman di setiap hari Rabu yang disebut dengan Am Mittwoch auf Deutsch bitte. Memberikan livet dalam bahasa Jerman berisi mengucapkan salam dan perkenalan diri.
Halo, guten Morgen, Frau. Ich bin Medan. Ich wohne in Sidikalang. Ich komme aus Kemenkes.
Menciptakan atmosfer Jerman di lingkungan kampus dan asrama Prodi D3 Keperawatan Dairy dengan cara menempatkan spanduk besar dalam bahasa Jerman berisikan ucapan selamat datang di Prodi D3 Keperawatan Dairy, membuat name tag setiap ruangan kantor dan asrama dalam bahasa Jerman. Melaksanakan permainan-permainan berbahasa Jerman. Menghafalkan lagu-lagu berbahasa Jerman. Penggunaan bahasa Jerman dalam beraktivitas hingga malam hari ketika tidur dan ibadah. Rencana Prodi D3 Keperawatan Dairy ke depan adalah melaksanakan Jerman Tour setelah 50% pelaksanaan intensif kursus atau les untuk mengevaluasi penguasaan bahasa serta meningkatkan perbendaharaan kosakata. Pelaksanaan evaluasi kemampuan berbahasa Jerman di akhir kegiatan. Jayalah Prodi D3 Keperawatan Dairy. Poltekkes Kesehatan Kementerian Kesehatan Medan terletak di Kota Medan. Medan merupakan ibu kota Provinsi Sumatera Utara, kota terbesar ketiga di Indonesia dengan penduduk lebih dari 2 juta jiwa. Poltekkes Kesehatan Kementerian Kesehatan Medan sebagai satuan kerja Badan Layanan Umum yang berada di bawah Direktorat Jenderal Tenaga Kesehatan Kementerian Kesehatan Republik Indonesia. Lokasi Direktorat Poltekkes Kesehatan Kementerian Kesehatan Medan terletak di Jalan Lejen Jaming Ginting, kilometer 13,5, Kelurahan Lauci, Kecamatan Medan Tuntungan, Sumatera Utara. Visi Politeknik Kesehatan Kementerian Kesehatan Medan menjadi institusi yang unggul dan kompetitif dalam menyediakan tenaga kesehatan di tingkat nasional dan siap bersaing di tingkat internasional tahun 2024. Misi Politeknik Kesehatan Kementerian Kesehatan Medan menyelenggarakan Tridharma Perguruan Tinggi yang kompetitif mengikuti perkembangan iptek, mempersiapkan SDM di bidang kesehatan yang profesional, bermoral, beretika, dan siap bersaing di tingkat nasional dan internasional, memperkuat jejaring dengan pemerintah maupun swasta tingkat nasional dan internasional.
Poltekkes Kemenkes Medan merupakan salah satu unit pelaksana teknis di bawah Kementerian Kesehatan yang berada di bawah Direktorat Jenderal Tenaga Kesehatan. Poltekkes Kemenkes Medan menjalankan fungsinya yaitu menghasilkan tenaga kesehatan yang profesional dengan melaksanakan Tridharma Perguruan Tinggi meliputi pendidikan, pengajaran, penelitian, dan pengabdian masyarakat. Secara administrasi, Poltekkes Kemenkes Medan dibina oleh Direktorat Jenderal Tenaga Kesehatan, secara teknis dibina oleh Kementerian Pendidikan dan Kebudayaan, dan secara tata kelola keuangan BLU dibina oleh Kementerian Keuangan.
Politeknik Kesehatan Kementerian Kesehatan Medan telah terakreditasi B oleh BAN PT dengan nomor SK 122-SK-BAN PT-AKRED-PT-6 2018. Terdiri dari 19 program studi. Program Diploma 3 meliputi Farmasi, Kesehatan Gigi, Teknologi Laboratorium Medis, Keperawatan Medan, Keperawatan Gunung Sitoli, Keperawatan Tapanuli Tengah, Keperawatan Dairi, Kebidanan Medan, Kebidanan Pematang Siantar, Kebidanan Tarutung, Kebidanan Padang Sidempuan, Gizi, Sanitasi, Program Sarjana Terapan Kesehatan meliputi Keperawatan, Kebidanan, Sanitasi Lingkungan, Gizi dan Dietetika, Pendidikan Program Profesi Bidan, Pendidikan Program Profesi Nurse, penambahan program studi lain di bidang kesehatan terus diupayakan.
Saya melaksanakan tugas direktur dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat sehingga menghasilkan lulusan yang kompeten dalam bidang kesehatan yang mampu mendukung transformasi kesehatan di Indonesia.
Saya melaksanakan tugas direktur dalam bidang administrasi umum, keuangan, dan kepegawaian. Di bidang keuangan, anggaran yang ada terdiri dari rupiah murni dan dari BLU atau Badan Layanan Umum.
Saya melaksanakan tugas direktur dalam bidang kemahasiswaan, alumni, dan kerjasama. Untuk bidang kemahasiswaan dan alumni, kita memberikan pelayanan kepada mahasiswa mulai dari proses penerimaan mahasiswa baru sampai dengan wisuda, dan termasuk untuk alumni dalam hal pendayagunaan lulusan Poltekkes Kemenkes Medan. Untuk bidang kerjasama, kita melaksanakan MOU dan MOA baik untuk instansi dalam negeri maupun luar negeri, dan juga bekerja sama dengan BEM dan UKM dalam pelaksanaan kegiatan di kampus, termasuk berpartisipasi untuk di event-event nasional dan internasional.
Dalam rangka menunjang kegiatan pembelajaran teori dan praktik, Poltekkes Kemenkes Medan didukung fasilitas seperti asrama, laboratorium terpadu dan jurusan, laboratorium komputer dan ruang CBT, laboratorium bahasa dan mini teater, perpustakaan terpadu dan jurusan, auditorium, klinik atau balai pengobatan, musola, bus dan mobil ambulans, sehingga lulusan Politeknik Kesehatan Kementerian Kesehatan Medan siap kerja dalam bidang kesehatan. Moto Politeknik Kesehatan Kementerian Kesehatan Medan, Smart, Santun, Mahir, Andalan, Ramah, Tanggung Jawab. Mari bergabung dengan Politeknik Kesehatan Kementerian Kesehatan Medan. Sehat tanpa korupsi, jaga diri, jaga teman, jaga Poltekkes Med, jaga Kementerian Kesehatan.
Medan Health Polytechnic of Ministry of Health is one of appointed health polytechnic as a pilot project for international class development. It is hoped that this class will excellent competitive and professional international class, especially for nursing class, and it will be pioneer for other departments that was already available in health polytechnic. Learning process and every subject of lectures designed to achieve graduates learning outcomes and interpreted with adaptive, communicative, creative, and innovative learning method.
Pengembangan kelas internasional Januari hingga Juli 2022. Tes TOEFL bagi dosen RKI jurusan keperawatan. Kursus bahasa Inggris bagi dosen keperawatan 2 kali seminggu. Mei hingga Juli 2022. Review kurikulum KI di Bekasi. Pembuatan RPS dalam bahasa Inggris. Sosialisasi RKI. Rekrutmen mahasiswa reguler RKI 17 orang. Agustus hingga Oktober 2022. English Day setiap Jumat. Workshop kurikulum RKI Prodi. November-Desember 2022. Berdasarkan SK nomor HK-02.02.4-2-6190-2021 dan SK nomor HK-02.03-F-3-1463-2023. Benchmark ke KI Fakultas Keperawatan Universitas Hasanuddin Makassar. Test of English as a Foreign Language Institutional Testing Program Maret hingga Juni 2023. Koordinasi dan audiensi terkait pengembangan kelas internasional. Mengikuti English Camp dan modul Camp di Poltekkes Salaman. FGD Workshop Kurikulum KI 15 hingga 17 Juni 2023.
Bismillahirrahmanirrahim. Pergi ke pasar membeli baju second. Bajunya bagus, harganya dibanting. Cakep. International conference will be open. I will open with a greeting. Assalamualaikum warahmatullahi wabarakatuh. Good morning and best wishes for all of us. Firstly, let's say thanks to our God Allah Subhanahu wa Ta'ala, the Lord of the world, who has been giving us His blessing and mercy, so that we can gather in this international conference of Medan Health Polytechnic of Ministry of Health 2023 with the topic Innovation in Controlling HIV/AIDS and Tuberculosis Among Mothers and Children. The Honorable Deputy Minister of Health of the Republic of Indonesia, Profesor Dr. Dante Saxono Harbuwono, SPPD, KAMG, PhD, the Honorable General Director of Health Workforce of Ministry of Health, Dr. Gigi Ariyanti Anaya MKM, the Honorable all speakers, Profesor Dr. Insinyur Zuraidah Nasution MKes, Lecturer of Nutrition Department in Medan Health Polytechnic, Associate Professor Dr. Wan Rohani Binti Wan Taib, Dean of the Faculty of Health Science, University of Sultan Zainal Abidin, Terengganu, Malaysia, Dr. Luh Putu Lila Wulandari, Research Fellow in the Surveillance, Evaluation, and Research Program at the Kirby Institute, University of New South Wales, Australia, Dr. Mansur Abdul Hamid from Faculty of Food Science and Nutrition, University Malaysia, Sabah, Dr. Diki Budiman Biomed MG, MSc, PhD from Research Global Health Security, Leadership and Risk Communication Center for Environmental and Population Health, Griffith, Australia University, Dr. Nola L. Holness, PhD from Florida University, and the Honorable Director of Medan Health Polytechnic of Ministry of Health, Mrs. R.R. Arini Winarti Dinawati SKM MKet, and all Deputy Directors, Head of the Academic and General Administration Section, and Head of the Academic Subdivision of the Medan Health Polytechnic, Head of Department and Study Programs within Medan Health Polytechnic of Ministry of Health, and then to be proud of all conference committees and all participants. Ladies and gentlemen, on this happy occasion, let me deliver an orderly event today as follows. First, opening by MC. Second, sing the national anthem, Indonesia Raya, and March of Medan Health Polytechnic. Third, prayer. Fourth, welcome speech from Director of Medan Health Polytechnic of Ministry of Health. Fifth, guidance and direction, as well as officially opening the event by Deputy of Ministry of Health of the Republic of Indonesia. Sixth, guidance and direction from General Director of Health Workforce. 8, the question and answer session. 7, conference topic presentation will be delivered by all speakers. 8, the question and answer session. 9, closing. Ladies and gentlemen, to shorten the time, we enter the next event, sing the national anthem, Indonesia Raya, and marks of Medan Health Polytechnic. I invite all participants to sit up straight in place.
Indonesia kebangsaan
Happy attendees, hopefully our program today can run smoothly to the end, so let us pray together with grateful prayer led by head of the Human Universities team of Medan Health Polytechnic, Mr. Muhammad Arshad Eskom. For Mr. Asad, time and place are yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, all of us. Before we start this event, let us pray according to our respective religion and belief. Let me lead the prayer according to the Islamic religion. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa ashabihi ajma'in. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Rabbi zidni ilma warzuqni fahma wa amalan salihah. In the name of Allah, the most gracious, the most merciful, all praise is due to Allah, Lord of all the world, the most compassionate, most merciful, Master of the day of judgment. You alone we worship, and you alone we ask for help. O Allah, we gather here today in your name and seek your blessing upon this second international conference Medan Health Polytechnic of Ministry of Health. We acknowledge your infinite wisdom and mercy, and we thank you for granting us the opportunity to come together in pursuit of knowledge and understanding. O Allah, we ask for your guidance and blessing upon the speakers, organizers, and participants of this international conference. Grant them wisdom and the ability to share their knowledge effectively. May their word inspire and enlighten those in attendance. O Allah, bless this gathering with unity, respect, and open-mindedness. Help us to engage in fruitful discussion and to learn from one another. Grant us the ability to contribute positively to the intellectual and academic atmosphere of this event. O Allah, we seek your protection from any misunderstanding or disagreement. Grant us the strength to overcome challenge and obstacles that may arise during this event. May the knowledge shared here be a source of benefit for all of humanity. O Allah, we ask for your blessing upon our educational institution and the pursuit of knowledge. Guide us to use the knowledge we gain for the betterment of society and the world at large. O Allah, accept our gathering and make it means of attaining your pleasure. We place our trust in you and seek your assistance in all our endeavors. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun. Wassalamun alal mursalin walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Thanks to Mr. Asad. Ladies and gentlemen, now we invite Director of Medan Health Polytechnic of Ministry of Health, Mrs. R.R. Arini Winarti Rinawati, SKMMK, to give welcome speech. To Mrs. Arini, time and place are yours.
Thank you for Ms. Pilar. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirrahmanirrahim. And the Honorable Deputy Minister of Health of Republic Indonesia, General Director of Health Workforce, Mr. Arianti Anaya, the Honorable all speakers. Thank you, Professor Dr. Insinyur Zuraida Nasution from Health Polytechnic, Associate Professor Dr. Wan Rohani binti Wan Taib from Terengganu, Malaysia,
So thank you to Dr. Luhputu Lila Wulandari, research fellow in the surveillance evaluation and research program from South Wales, Australia. And thank you, Dr. Mansur Abdul Hamid from Faculty Food Science and Nutrition from University Malaysia, Sabah. And then, so thank you, Dr. Diki Budiman, BMed, MD, MSc, PhD, Research Global from Health Research, Environmental and Population Health Griff, University Australia. Muhammad Ahmed Al-Junaid, DDS, MDS, Doctor of Dental Surgery, Faculty of Dentistry, Eden University, Yemen. And the Honorable Deputy Directors, Head of the Academic and General Administration Section and Head of Academic Subdivision of the Medan Ministry of Health Polytechnic, Head of Department and Study Program within Medan Health Polytechnic of Ministry of Health. And then, so I'm so proud of all conference committees and all participants. The 2023 International Conference will take the theme Innovation in Controlling HIV/AIDS and Tuberculosis among Mothers and Children. The theme is in line with the Medan Health Polytechnic Center of Excellence in Science and Technology, namely Matters and Child Health. National data showed the most HIV transmission to the children occurs through transmission from pregnant women to the fetus. In fact, 90% of cases of HIV transmission to children are transmitted by pregnant women to the fetus. Therefore, efforts to control HIV cases in adults will influence to occurrence of transmission to children. Transmission from a pregnant mother to the fetus can actually be prevented through HIV testing. Babies who have been infected with the HIV virus will experience and decrease in the immune system, which attacks CD4 cells of types of white blood cells or lymphocytes. Two, to the decreased immune system, babies infected with HIV virus will more easily fall ill. HIV infected children also often experience fungus in the mouth. Then he suffered from diarrhea for a long time and even pneumonia, inflammation of the lungs. This condition almost certainly contributes to stent growth in babies. Therapy effective the baby's nutritional status. Likewise, with TB disease, there are many dangers that threats pregnant women. If they suffer from TB, one of the risks and may arise for the baby in the baby born with a very low birth weight. Even in the worst condition, baby growth will be slow. The activity target, the main target in this international seminar activity and wave lecture at the Medan Health Polytechnic. However, it does not rule out of possibility of opening opportunity for lecture outside the Medan Poltekkes. And then purpose of activity, participant get the last information related to the research that arise the issue of HIV/AIDS and TB in mothers and children. Innovation that can be developed can result of research to control HIV/AIDS and tuberculosis in mothers and children. These activities support the health transformation program and health polytechnic. So I hope this activity is used optimally. Thank you to the Director General and the Deputy Minister for giving the Polytechnic the opportunity to develop. Please always accompany it so that it can quickly move to become a world-class polytechnic. And thank you for all speakers, committee, and participants that has been participated in this international conference. We pray that all the event will be run smoothly. Thank you. Billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. That's the welcome speech delivered by Mrs. Arini. We thanks to Mrs. Arini for your welcome speech. Ladies and gentlemen, now we move to the next agenda, that is guidance and direction, as well as officially opening the event by Deputy of Minister of Health of the Republic of Indonesia, Professor Dr. Dante Saksono Harbuono, SPPD, KAMG, PhD. For Professor Dante, time and place are yours. Please, Professor Dante was joined to Zoom. Okay. Good morning, Professor Dante.
Yes, good morning, everybody.
Okay, thank you.
Yes, Assalamualaikum warahmatullahi wabarakatuh. Good morning. Good morning, greeting to all of us. Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Welcome to this moment occasion, the International Seminar of Innovation in Countering HIV/AIDS and Tuberculosis among Mothers and Children. I would like to express my highest appreciation for you all, and it's great pleasure to me to meet you in this event. Ladies and gentlemen, esteemed colleagues and honorable guests, allow me to start his speech timeless word of Nelson Mandela, who once said, health cannot be a question of income, gender, it is a fundamental human right. As we gather here today, this word resonates profoundly, guiding our effort to address the HIV/AIDS tuberculosis control, including our most vulnerable groups, maternal and child. Based on the current data, HIV and tuberculosis have been rising concern viewpoint of the well-being of mother and children. From our data, we record there is 700,000 new tuberculosis cases in 2022, with mortality rate of 155,000 cases and equivalent to 7 deaths per hour. Almost 10% of it was children cases. The preventable therapy is not only reached 5% of the target along the same year. This is 500,000 new HIV cases in 2022. There is 14,000 children cases, 7,000 mother cases. Among this maternal infection, 76% of them is not starting SRV immediately and resulting a higher cost transmission to fetal. This number underscores the current urgency with it. We must approach the dual challenge of preventing and treating HIV and tuberculosis in the most vulnerable member of our society. Ladies and gentlemen, in the response to this challenge, the Minister of Health of Indonesia has been committed to control HIV and tuberculosis, including of mother and children. Vigorous initiatives have been undertaken. The aim has been not only to treat but to prevent, fostering a society where health disparity are minimized, if not eradicated. For tuberculosis, we roll out first regulation to ensure every tuberculosis screening and treatment regimen is free of charge, and national budget for overall tuberculosis program is sustainable by inserting it to Indonesia long-term national plan. Facilitated more 2,000 unit rapid molecular test machines for tuberculosis diagnosis covering 501 districts and cities across 34 provinces to ensure surveillance can have a significant impact. Public-private collaboration, one of sample managing the linkage between tuberculosis mandatory notification and health facility accreditation. And also massive active cases finding based on family and community are using an advanced reporting system we call as SETB, which integrated with tuberculosis diagnosis tools and national health information system. And the last one, strengthening overall community involvement and communication. That is very important. For SIV, we rule out first regulation for sustainable budget of mandatory triple elimination of maternal health check, HIV, syphilis, and hepatitis B. And second one, mother with HIV positive will facilitated with HRV, including the provision HRV consumption team to maintain the sustainability and reach desired parameter before labors. And the last one, strengthening overall community involvement and communication, especially for partner notification and the importance of HRV treatment immediately after tested positive. Ladies and gentlemen, however, our work is not complete yet. The path ahead toward Indonesian HIV and tuberculosis elimination by 2030 require collaboration effort where the realm of education and research becoming our guiding light. Today, I call upon STEM researchers and academicians present to join hands in this noble endeavor. On behalf of Minister of Health Indonesia, I do hope this event would end with the output strong recommendation for document for Indonesia further innovation on HIV and tuberculosis control. In conclusion, I extend my deepest gratitude for each of you commitment to these causes. My collective effort echo through the annal history as we strive to make Mandela vision on reality, where health is not privilege but undeniable human right. By saying Bismillahirrahmanirrahim, I open this seminar in for you. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. We'd like to thank Prof. Jante Saksono Harbono. For Prof. Jante, we can get documentation, please. For IT, take your photo. Yeah. Just a minute, Prof. Dante.
With all speakers. Thank you.
Yes, with all speakers, please. Yeah. Okay, thank you.
Terima kasih, Prof. Dante.
Terima kasih, Bu. Terima kasih.
Once again, we would like to thank Prof. Dante Saxono. For Prof. Dante, if you still want to join this conference, we are very, very happy. But if you still have other activities, we really understand. So once again, I say thank you all for your willingness to join us, Professor Dante. Okay, thank you. Ladies and gentlemen, the next event should be guidance and direction for General Director of Health Workforce of Ministry of Health, Dr. Gigi Arianchanaya, but she has some ongoing activities. She will can join later. So we move to the agenda, the next agenda. That is topic, presentation of all topic with this conference. I will divide it into 2 sessions. The first session will feature 3 speakers, who is Dr. Diki Budiman, Biomed MD, MSc, PhD from Griffith Australia University. Next, Dr. Luh Putu Lila Wulandari from University of New South Wales. And then Professor Dr. Insinyur Juredah Nasution MKes from Medan Health Polytechnic of Ministry of Health. For this event, we'll be guided by our moderator, Ms. Kirana Patrolina Sihombing. But before that, I will read the curriculum vitae about Ms. Kirana. Please share curriculum vitae about Ms. Kirana, please. Yeah. Ms. Kirana, born on April 1983, is a lecturer in the Department of Dental Health at the Medan of Health Polytechnic. She is graduate of the Biomedical Science postgraduate program at Gajah Mada University and continuing postgraduate studies in biomedical science at the University of North Sumatra. With extensive research experience as evidenced in this slide, okay, her most recent work involves studying the effectiveness of oral and dental health education media intervention in preventing risk factors for tooth decay among elementary school students in Medan City and post-COVID-19 pandemic village in Dairi Regency. Ms. Kirana has a significant number of journal publications, but nationally or internationally, she has also developed several modules, including a module of basic anatomy and physiology. Sorry. Okay. So a glimpse of Miss Kirana, and the next for Miss Kirana, the event I submit to you. Thank you.
Thank you so much to Ms. Wardati Humaira, who has delivered this session to me. I want to ask about, am I audible now, Ms. Wardati Humaira? Do you hear my voice?
Yes, ma'am.
Okay, thank you so much. Okay, ladies and gentlemen, good morning. Thank you so much for your presence in this session 1 of our conference. I hope all of us is in healthy and high spirit to participate in this event. My name is Kirana Patrolina Sihombing. I will be as a moderator in this session today. I am a young lecturer in Medan Health Polytechnic of Ministry of Health of Medan. I am honored to stand before you today as we prepare to engage with our distinguished speakers who will be sharing this expertise and insight of us. It is my pleasure to introduce all speakers in session 1 whose knowledge and experience in providing information about HIV/AIDS has inspired people to successfully make an innovation in controlling the disease. First, our speakers today is Dr. Diki Budiman Biomed, MD, Master Science PhD from Griffith Australian University. Hello, Mr. Diki Budiman.
Assalamualaikum. Hello. Good morning
Hello.
from Paris.
Thank you. Waalaikumsalam. How are you today, Mr.?
Alhamdulillah. Alhamdulillah. I'm good. Thank you.
Thank you very much. Okay, second speakers is Dr. Luhputu Lila Wulandari from University of New South Wales, Australia. Hello, Miss Luhputu.
Hello. Hi.
How are you? Okay, I have hear your voice. Are you okay?
Yes, yes.
Okay, thank you very much, Dr. Lu. And our third speaker is Professor Dr. Insinyur Zuraidah Nasution MKes from Medan Health Polytechnic of Ministry of Health. Hello, good morning, Professor Zuraidah Nasution. Good morning, Prof.
Will be joined later, Miss Kirana.
Oh, okay. Okay, thank you. Let me information to you all our speakers that our audience are from faculties, researchers, and also students. So it is quite various background. Okay, for the first speakers, Dr. Diki Budiman, with an impressive academic and professional background that we can see from his curriculum vitae, Dr. Diki Budiman has consistently demonstrated extraordinary dedication to the areas of health security strengthening to health system improvement support. He holds a PhD on global health security, risk communication, leadership, and ethnic public health from Griffith University, which studies and research experience, and his work has been recognized both nationally and internationally. Dr. Diki Budiman has made a lot of publication, work, and models, and also has 26 years working experiences. His current working status is as the policy advisor to Minister of Tourism and Creative Economic Republic of Indonesia, and also as resources person on global health and security in ASEAN region. In the seminar, Dr. Budiman will present with the topic HIV and TB control, including to the latest advances and trends in the health sector regarding from health security strengthening to health system improvement at national and global level. Deep understanding and the ability to communicate complex ideas in a clear and engaging manner will undoubtedly give us a deeper understanding of this topic. Our seminar today is not only an opportunity for us to learn from Dr. Diki Budiman, but also to engage in deep discussion and exchange perspective. I encourage you all to actively participate and utilize the weight of knowledge that Dr. Diki Budiman will share to all of us. So without further ado, for the next 20 minutes, we will listen the presentation of Dr. Diki Budiman. So to Dr. Diki Budiman,
Okay,
Time
thank
and
you.
place are yours. Thank you so much.
Okay. Thank you, Bu Kirana, and good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Greeting from Paris. I'm in Paris now, attending also some meeting. Thank you for the organizing committee for having me on this very important seminar, because HIV and TB disease is the disease that facing by human for a long time and still become the global health threat, especially the global health security threat, due to their impact not only to health but also to other sectors like social, economic, and even politics. So today I will share with you the HIV and TB control, especially the perspective from health security, and also how we can deal with the health system improvement to deal with this disease. Next slide. So I have deal and also involved with this disease TB HIV for since 2000. I mean maybe before 2000, since I was working in Puskesmas or community health center in West Java and in Tasikmalaya, and also during my first working experience joined with MOH in early 2004, I think. I also involving with many WHO and national program to establishing the HIV/AIDS program in Indonesia and also in ASEAN. And during that time also I contribute to several publication and also survey and research regarding the HIV/AIDS in Indonesia, as you can see in my slide here in the right side. Next slide. And again, now after almost 26 years of my working experience, we still see, and I still see, that the HIV and TB still become our problems. And even there is some improvement, especially for HIV. And in past and previous past year, the TB also program reached some improvement, but there's still also some gaps and challenges that we face for these two infectious disease due to several factors. And the main problem is about the inequity, and also of course the current situation, climate change, mobilization, the politic, health governance, and others factor also contribute to our challenges in this new era. And as we've seen in this slide, the burden and also the impact of this HIV/TB disease or co-infection is very clear, and we can see in many places, in many countries, in many regions, and it's not only related to the Black people in Africa, but also to Asian, to also Caucasian, and many others. And in every different background, if a different gender, impacted by this HIV/TB directly, indirectly. Next slide. Please, next slide. Next slide, please. Next slide, please. Okay. Yeah. And if we look at to the several research for HIV and TB, then we see that HIV has shown that around 40 million people living with HIV, and annually we have 2 million new infection for HIV, which is very, very high. And annually also around 1 million people die due to HIV. This is only from one disease, and that's huge number. Even we already seen the decreasing number of this mortality rate, but still 1 million is still big, and even 1% is still also big for the mortality due to the disease like HIV. And TB in another side also one of the world top infectious killer, and Indonesia also contribute to this what's say worsen of this infectious disease or respiratory infectious disease. And compared to HIV, TB has higher new cases every year or annually, which is around 10 million. And also the number of death due to TB also higher than HIV, which is around 1.5 million TB death. And you can imagine when the two diseases above combined and also infected one person, the impact will be very serious. And that's why today we discuss and I will share with you the current and the latest update of what this disease and also its relation to the global health security activities and also program. But if we talk about HIV/TB co-infection program, even we already aware about how important of this combination previous. But still, next slide. But still, we face also several challenges when we want to, next slide, when we want to run this TB and HIV program. The first challenges is about the high disease burden, because 1.2 million cases of TB among people living with HIV. If we refer to the previous slide, 1.5 million of new TB cases annually. So more than around 90% of the TB cases it infected HIV positive patient. That's very important message for the first challenges. The second, TB therapy is difficult to take because it require the complement, not only medicine, but also he or she will need the social protection, social support in taking the medicine, because at least 6 months they have to take this medicine daily, and that's can also affect adherence. And the last one is the drug-to-drug interaction, because TB treatment itself is not only one medicine. So there will be several tablet or pills. And in the other side also, people who has HIV infection will take also antiretroviral treatment, which is not only one pill or tablet. So there will be another challenge or problem. It's about the drug-to-drug interaction, which is still challenging and evolving during these years. Next slide. And again, when we face the one of the worst pandemic in human era in the last 3 or 4 years, the corona infection, which is COVID-19 infection, also weakens our effort, including Indonesia effort against HIV and tuberculosis, because in many parts of the world, the program for ARV or TB treatment is reducing, and the drop out number of patients who take the medicine also increasing. So this is also another problem facing by this HIV TB co-infection program. Next slide. And of course, from this slide also we seen the global support to the TB HIV also reducing during the pandemic COVID-19, and that's will can have very serious effect to the country, like including in Indonesia. Next slide. And in the other aspect also, the other aspect that facing by the HIV TB co-infection is about the stigma. The stigma of those two diseases is almost similar in terms of the persistent stigma the patient facing, even the family facing. Even it's in different, little bit different perspective, but the stigma is still there. But the the program to dealing or with the stigma is also still challenging, because it's related to also how successful of the program itself in improving the health status of the patient. And the stigma of these two diseases influence the successful of the TB HIV co-infection program treatment. Because, for example, for HIV stigma, immorality stigma addressing to the patient is very high, and also it make the patient, it's not easy to come to the health center to get their treatment, because they want to cover their status. And in the other side also, the stigma and also contribute to the low coverage of the early detection or HIV detection. And next slide. This also the two of the disease also contribute to the decreasing health and welfare status of the nation. Because, for example, in Africa country, especially in Saharan area, the life expectancy at birth in those countries is reducing due to the HIV and TB infection. And that's mean the number of people who achieve more than 60 or 70 years is reducing, and that's where can contribute to or affect to the serious problem of the welfare of the country and nation. This is due to the the high mortality rate from the two diseases. Next slide. And if we look at to those challenges, previous challenges that I already mentioned, the also the serious impact not only to health but also to other sectors, then I would like to raise the how important of the global health security action program to addressing the TB HIV co-infection program. Because as we seen during the pandemic, the impact of one disease like COVID-19 become pandemic has raised the awareness, understanding that the global health is very important, because without global health, the national or local health cannot be achieved. And in vice versa also, without local and national health, the global health also cannot be achieved. So this is something that also bear should be bear to our mind, that the global health security is one aspect that's very relate to the daily activities and also relate to the disease like HIV and TB. And of course, without this program, then we cannot have the healthy people and also welfare community. Next slide. Next slide, please. And of course, as we seen from the slide, my slide, this slide, the global health security threats already has several, I would say, already identify several threats for around the globe, and one of them is about the HIV, AIDS, and tuberculosis or TB, because this become the disease that impacted not only health but also other sector and also cross borders, and also due to our globalization, high trade and also high mobilization of the people, the HIV and TB disease also, it's easy to spread in the global community. And if we look at to the global data, the AIDS is the leading cause of death still among a woman of reproductive age, and that's also will contribute to the next generation, because when one problem, serious problem, disease or others aspect facing by the woman and young woman or young girl, it will impact the next generation, because woman and young girl, we the one who very important to take care and also of course to having baby for the next generation. And this is the problem facing by them due to the HIV AIDS. And unfortunately, only 60% of people with HIV know their status, and remaining also 40% still need access to HIV testing. In this occasion, I would like to raise awareness and also, let's say, enthusiastic of the audience, young people, older people who has active in not only sex but also in activity, especially the health workers, to know their HIV status. This is also very important, not only to know our status of HIV infection, but also to reduce the stigma. Myself already done this test for me 3 times, and so far, alhamdulillah, still negative. But that's to show my what to say example to my college and also my student, that everyone should know their HIV status, and that's not relate to their moral and not relate. It doesn't relate to the what say it's a stigma list that I already mentioned in previous. But we need to to support this program also. One of the early and very important aspect is about the to know our HIV status, and especially for the one who young, and even not only young, but the one who has multiple partners and also has also another high risk behavior. It is very important, and that's very the benefit to know our HIV status is also to get early treatment, and so the people can still have let's say quality life and also prevent the AIDS stage of the HIV infection. Next slide. And of course, without the resources to deal with the HIV TB in co-infection program is impossible, because many countries in the world who face with the HIV TB, majority and categorized lower middle income country, or maybe even lower, let's say, and developing country, or in the poverty line, if we look at the vulnerable groups. And one major challenge that they face is about the funding aspect. And so far, the Global Fund, UNAIDS, and others also helping those countries in establishing the program and also running the program. And of course, this is not only from the global health support, but also at the national and local, also very important when they prioritize their budget and prioritize their health program in dealing with this HIV TB, especially when the region or the province and the district is under categorized of this epidemic status. Next slide. And the problem for global and also in Indonesia, that the number of TB, HIV infection is still in high rate, and the majority infected is still women and girls, and also children among the vulnerable group that infected by HIV, which is why we also have today seminar. It's because without addressing this issue, especially for women or mother and to their infant and children, so it's mean, for example, Indonesia or Medan, for example, will not contribute to Indonesia Emas or Gold Indonesia, because the young generation or the mother who responsible to educate and take care of the young generation in ill condition. So that's why this HIV TB co-infection program is very important. And again, 46% of all new HIV infection in last year is among women and girls, and this is something that we have to address. Next slide. Why we need to address? Because when young girls, women having baby or pregnant, so the risk of HIV transmission, or we call it perinatal transmission, is also will be there, and increasing if they don't get the ARV treatment. And if we look at to the global data, last year, 82% of pregnant people with HIV had access to ART to prevent transmitting of this HIV. But again, if we look at very, let's say, more detail on the data, majority of the data come from developed country, and or the country who has supported by Global Fund, for example. But if we look at to region, local situation, especially when the Global Fund and also UNAIDS program and even the national program is not there, so the issue is still there. The access to the ART for pregnant women is still there. Yeah, next slide. Especially because they even many of them also doesn't know of their HIV status during their pregnancy and before even. And in the other side, I would like also to take us to look a little bit more detail on the tuberculosis as a threat to the global health security. As I already mentioned before in my previous slide, TB has recently surpassed HIV as the world leading infectious killer. As I already mentioned, they have higher newly infection annually. They have higher also mortality date. I mean a number annually. So this put TB as the on very serious.
I'm sorry.
What's it? Yes.
Excuse me, Mr. Ricky.
Yeah, Bu
Your
Kirana.
time is remaining 5 minutes.
Okay. Thank you.
Okay, you're welcome.
And that's why the TB, as I already mentioned, the majority of TB patient is among HIV patient. So it's including the new infection. So that's why the TB HIV infection is very important program. Next slide. I will try to make it fast then. But when we want to improve and strengthen our TB and HIV co-infection program, we need to also to have the reform, like what MOH Indonesia now has the transformation reform, reform program. We need to change strategy and our action, and we should start it with our effort to reducing the stigma, because without reducing the stigma, the access to information to services is still become a serious issue. Next slide. And when we also try to change the politician, policy maker, and bring them the awareness, not only to them, but also to the population, I mean the public, we have to remind them about this several points, that the impact of HIV on TB or impact of TB on HIV is also in vice versa is very serious. And you can mention about this, the increase of mortality and also the complicate of treatment, like I already mentioned before. Next slide. And as we know, if we don't address this issue, then we will face this problem, like I already mentioned here. The people living with HIV are 14 or 18 more time more likely to fall ill from TB compared to people without HIV. So this is very serious. And next slide. Next slide. And that's why the TB HIV co-infection program should also establish in every region and also every level, and to also comply with the sustainable development goals target, and also and under the UNAIDS target. And next slide, next slide. Next slide, please. Yeah, it's okay. Then we need also to contribute to the reducing the number of infection. Next slide. Next slide. Next slide. Okay. Next slide. Next slide. I try to make it, but fortunately, we are not on the list of these 10 countries account for almost half of new HIV infection. But this is not always a good news, because we have to support this good news by also provide a strong program in early detection, or in terms of HIV testing, also in TB diagnostic. I have to also bring to all of us the awareness that in Indonesia context, the time from patient TB to be diagnosed is very timely consumed, because it around need more than 1 month, more than 1 month for people who got the TB infection get diagnosed as a TB patient in Indonesia. That's the latest research in Indonesia. So during those 1 month period, so he or she already transmit the disease to many people. That's very serious problem. Next slide. Next slide. But again, to deal with this global health security threat, we have to have this sustainable and resilient system to not only again those two the infectious disease, but the health system in general, the healthcare delivery and others. The human resource is also become a very important part of this program. Next slide. As we can see in this slide, that under the any kind of disease, the aspect of out of health sector is also very important, contributing to the successful of the program, because without nutrition, without the good health what to say good environment and sanitation, we cannot have the good quality of health. Next slide. Next slide, please. But again, based on several research, we still have to address the several challenges in terms of these HIV and TB, and lesson learned, best practice is become also very important in improving the program. Next slide. And again, we have to also refer to the global program and implement it and translate this global program to the local situation. Next slide. Next slide. And for example, for country like in UK, for example, they already have this program, and if I can say, if when we making or establishing or writing, developing the health security strategy, for example, for HIV and TB, of course we can have a long term, but it's very important to make it in detail in very short term, because this disease evolve very frequently, and we have to updating regularly to our program. So when we make this and in short term, it's easier for us to deal with this evolving disease, and especially now we will have also what to say factor or effect from the others disease like COVID, or even the global situation like climate change. Okay, that's next slide. That's my last slide, and please let's say raise the question if you have any unclear statement or explanation. I'm very happy to answer. I give back to Ibu Kirana for this session. Thank you.
Thank you very much, Dr. Diki Budiman, for your great presentation. And maybe all the participants, if you have any questions for the explanation of Dr. Diki, you can type your questions on the chat box, or maybe when our discussion, you can raise your hand from the Zoom's menu in the bottom. Okay, thank you very much, Dr. Diki. Give applause to Dr. Diki. Okay, now we will continue. Yes.
Ibu Kirana, I'm sorry.
Yes.
Due to my constrained time schedule in Paris now,
Okay.
if there is what's a question an answer during this session, I'm allow me to answer to my WhatsApp and send to the organizing committee, because in another 20 minutes I have to attend another session. I mean occasion in here. Thank you, Sam.
Okay, okay. Thank you very much, Dr. Diki. To all participants, as the Dr. Diki said that all of us can make a questions, and you can deliver your questions for the committee or from WhatsApp and maybe from this chat room, so that we can deliver our questions to the Dr. Diki. Thank you, Dr. Diki. Now we will move to our second speaker. Second speaker is Dr. Luhputu Lila Wulandari. Hello, Dr. Luhputu. How can I call you? Dr. Lu?
Wulan, please.
Dr. Wulan.
Can call
Okay.
me. Yes.
Thank you very much. I would like to read the profile of Dr. Wulan. Dr. Wulan, with an impressive academic and professional background that we can see from her curriculum vitae, Dr. Wulan has consistently demonstrated extraordinary dedication to the areas of health, especially to integrating programs from the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B into antenatal care, addressing gaps and seizing opportunity support. Dr. Wulan is a researcher fellow in the surveillance, evaluations, and research program at the Kirby Institute, University of New South Wales, Australia. She is also as academic at Udayana University of Indonesia. I have noticed from Dr. Wulan's that she has a lot of research, which most of her studies is about HIV, pharmacy, medication, and surveillance. And her working also as editor and reviewer has been recognized both nationally and internationally too. Today, Dr. Luhputu Wulan will share her presentation for 20 minutes, insights on creating a more sustainable future through innovation and collaboration. I hope that Dr. Wulan can share the presentation and for 20 minutes. Okay, Dr. Wulan, get ready to be inspired, challenged, and empowered to take action. Ladies and gentlemen, please join me in warmly welcoming the exceptional Dr. Wulandari. To Dr. Wulandari, time and place are yours.
Okay. Thank you, Ibu Kirana, and thank you so much for the committee for the opportunity to present my study here. And thank you so much, Dr. Diki Budiman. I think your presentation is really provides me with a very good background for what I will be presenting later in my presentations. Ladies and gentlemen, I think we saw from Dr. Diki Budiman's presentation just now that there are HIV and TB is still among the most important public health issues worldwide in Indonesia. And his presentation also covers why it is really important to start or focusing the interventions to reduce the transmission from mother to child transmission of HIV. Now I would like to share my screen. Okay, can you see my screen now?
Yes, ma'am.
Yes, we can see.
Yeah. Okay, thank you. So I think my presentation now is really a good follow-up after Dr. Diki presentation. The title of my presentation is Enhancing Triple Elimination Interventions for HIV, syphilis, and hepatitis B in Indonesian antenatal care settings, addressing the gaps and seizing opportunities. Actually, what I would like to present now is the results of my study with my other colleagues from Udayana University, the Kirby Institute, University of New South Wales, and also the author from the Ministry of Health of Indonesia, and other authors from the other institutions. Okay, not sure what happened to my screen now. I see the line now at the top side of my screen. Anyway, so the background, I think, again, I said, I would like to say thank you to Dr. Diki for presenting a good context for my presentations. Yes, it is really true that HIV and TB is really important public health issues worldwide and also in the country. And if we saw the data from the WHO, and I think Dr. Diki has presented this data just now, every year almost 1.3 million women and girls globally while living with HIV become pregnant, and that's how huge the burden that we are trying to solve if we're going to intervene or provide intervention on HIV in antenatal care settings. And we saw from a lot of study which found that the risk of HIV transmission from HIV positive women to her babies during either pregnancy, delivery, labor, or breastfeeding is between 15 to 45% in the absence of interventions. So without the interventions, it is likely that there is a 15 or 45% of transmissions of HIV from mother to child during the pregnancy, delivery, and breastfeeding. And due to this importance, it is important that as soon as HIV infection is confirmed in the mother, a link to treatment and care for the rest of one's life should be made available, along with assistance in staying in treatment and receiving viral suppression, as well as partner services. The same as hepatitis B virus as well, because now the program is trying to really integrate HIV, hepatitis B, and syphilis. So I would like to share a bit about the hepatitis B problems. Here we can see that despite an established immunoprophylaxis strategy to prevent transmission of hepatitis B from mother to child, it remains the primary route of hepatitis B transmissions from mother to child worldwide. And it is estimated that between 70 to 90% of newborns born to mothers who are tested positive with hepatitis B E antigen and hepatitis B S antigen will contract HBV during the pregnancy if no treatment is provided. And the same also with syphilis. During a lot of study have provided evidence that during the first 4 years of the disease, a woman with syphilis has around 70% likelihood of conceiving a baby infected with the virus if she is not treated. So from this, we can see that testing and treatment is really important and really crucial if we want to really eliminate the transmissions of HIV, syphilis, and hepatitis B from mother to child. Actually, there are the WHO especially has already aware of these issues, and there are a lot of documents, policy guidelines, and evidence to support the importance of these interventions, and also to provide recommendations to countries highly at risk of this disease to act on the problems. One of the documents that the WHO Western Pacific Regional Framework has been issued for the triple elimination of mother-to-child transmission of HIV, hepatitis B, and syphilis in Asia and the Pacific, 2018 and 2030. And this is, I think, the cover of the documents. You can Googling it if you want. And in response to these documents, again, the Indonesian government is actually has already declared the same commitment towards this goal by the issuing of the Ministry of Health regulations on elimination of HIV, syphilis, and hepatitis B transmission from mother to child. And this regulation can also be downloaded from the website. In addition to the regulation, the Ministry of Health also issued a guideline on the implementation of prevention of mother to child HIV, syphilis, and hepatitis B transmission at the antenatal care setting. So there are a lot of documents that has been provided to provide health staff guidelines on how to do the EMTCT, we call it, or elimination of mother to child HIV, syphilis, and hepatitis B transmission from mother to child. Now, despite this commitment, despite the programs that has been implemented for a couple of years now, there is a limited focus or attention towards how actually the stakeholders views on the program, and what is the gaps and opportunity for the program implementation to address the problems that they face in the field. And again, there is limited published data on this evaluation, and that's where my study, along with my colleagues in other institutions, trying to fill this gap by looking at the stakeholders' view on the EMTCT or PMTCT program in Indonesia after the integration of HIV, syphilis, and hepatitis B prevention program or intervention at the antenatal care settings. So we did our qualitative study in 2 provinces in Indonesia. The study was conducted in around 2019 and 2020, so just before the pandemic. We chose Bali and West Nusa Tenggara for a purpose that Bali was representing one of the province with good HIV testing among antenatal care settings in the antenatal care settings, while West Nusa Tenggara is one of the province with limited data around that program. So we would like to compare between the 2 provinces. In this qualitative study, we did focus group discussions and interviews. We can see from the picture there. When I did the focus group discussion with various stakeholders in Bali and West Nusa Tenggara. We did interviews with provincial. Yes.
Excuse
yes,
me,
sorry.
Dr. Lu Wulandari.
Yeah.
We have to stop for a moment because our General Director of Health Workforce, Dr. Gigi Arianti Anaya, will join for us.
Right. Okay, that's okay. Thanks for letting me know. Maybe we will continue after her. Thank you.
Hello, Ms. Wardati Humaira.
Okay. On to the next event.
Yes, because
we stop at the presentation. That's presentation.
yeah.
Okay. Okay, thank you. Ladies and gentlemen, General Director of Health Workforce of Ministry of Health was joined to that Zoom. So we stop presentation and next event again. That's guidance and direction from General Director of Health Workforce of Ministry of Health, Dr. Gigi Arianti Anaya, MKM. Firstly, I will greet Mrs. Arianti. Hello, Mrs. Arianti. No join? Okay, Miss Arianti, not join at Zoom. Miss Kirana, I think you next presentation.
Oh, okay.
Sorry, Miss Lu. Okay, I submit to you again.
Okay.
Okay.
Okay. I'm sorry to Dr. Wulandari because our deputy director is not joined yet. Maybe after she's joined, we can stop for a moment. I'm sorry for that. We can continue
Okay.
to the presentations.
Yeah. Okay. Understandable. So I will then continue my presentation then.
Yes, thank you so much, Doctor.
Yeah. So I think this is where I stopped just now. So let's continue from this. So we did a focus group discussion with interviews with various stakeholders in Bali, from the provincial health offices, the district health offices, and the midwives from private midwives, and also the village midwives. And the FGD and the interview guides cover a couple of questions around the implementation of the EMTCT or PMTCT and operational aspect of the program, including the challenges and the opportunities they faced by the stakeholders in the field. Okay. I am okay. The interviews approximately conducted in maybe 45 minutes, and the FGD was conducted in about 2 hours. And the data from the FGD and the interviews was transcribed, and the transcriptions was used in the analysis. And the analysis was conducted or performed using in vivo, a software particularly good for qualitative research, and the thematic analysis was done in the analysis. This is just a bit of the participants who were involved in our FGD and interviews. There were 18 stakeholders participated in our study, including from provincial health office, district health office, Puskesmas staff, village midwives, midwives from private clinics from the 2 provinces in the study area. And the results can actually be grouped into 2 big themes, which are the problems or challenges, and the second one is the opportunities. For the challenges or the problems, there are a couple of things emerged from the interview, including the challenge around rapid test kit stock outs for the HIV, syphilis, and hepatitis B, lack of skills among staff in supply chain management, lack of staff training. So there was no sufficient number of staff who can conduct the test, high staff turnover, the complexity of information and reporting mechanism for the EMTCT program, which overwhelmed the staff in the field actually, and stigma and discrimination, and the challenges to involve the private sectors for the program were among the challenges experienced by the stakeholders in the field. For the potential opportunities to improve the coverage of testing, this include the use of social media group, which is WhatsApp group, to improve communication among staff and coordination to improve program performance, and also the use of prenatal class at the village midwife as a venue for providing testing to the women during the ANC care. So this is just a couple of quotes that represents each of the themes from the interview results. So the first one is around lack of staff training. We can see here from one of the quotes from the participants. The first is a problem related to staff capacity. Then the staff is also sometimes not available. Then even if there are staff, they are not adequately trained to carry out the test. For the lack of skills in supply chain management, we can see the quotes here from one of the interview participants. The kits were actually available at the provincial level. However, to distribute it to the district, there needs to be a request from the district. And if they or the district don't put a request, we can't distribute it. So there are issues around coordination on how to order the kits here. Rapid test kit stock outs. In fact, there are a lot of quotes for this team. A huge number of participants mentioning that they often experience a rapid test kit stock outs during the implementation of the program for HIV, syphilis, and hepatitis B logistics. And also high staff turnover from what is provided in the example below. The staff are often moved to other divisions, so the new staff doesn't know how to do the test. The complexity of information and reporting mechanism for the program of testing for HIV, syphilis, and hepatitis B at the antenatal care testing. The obstacle we face is the same. We don't have much time to record and report to the health office because there are too many data. We record everything, we enter it into the paper-based registration, then we enter it into the computer online, then we send it to the district health office. So it seems here that the staff is really overwhelmed with the tasks that they need to accomplish regarding the recording and the reporting of the program. Stigma and discrimination also emerge as one of the themes from the interview. We can see from the examples of the quotes here. Basically, they are saying that the women who are tested positive are unable to be followed and came to our clinic without informing us their HIV status. And also the challenges to involve the private sectors, especially the obstetricians. There are some who were involved in the program. They are willing to refer their clients to the Puskesmas, but not all of them to doing so. Some others are still not referring their clients to the Puskesmas for testing. And the potential, that's the above are the challenges. Now we look at the potential of the activities that might improve the program performance. The first one is looking at the potential use of mother class at the village midwives to improve the coverage of testing. So basically the staff of the Puskesmas are coming with their kids and everything to the village midwife venue, and they invited the woman there and asking the women to test in the village midwives centers. And also the potential use of social media group. In this case is a WhatsApp group among the staff at the DHO, Puskesmas, and village midwife to improve coordination and share information and updates regarding the HIV, syphilis, and hepatitis B testing. So the conclusion, this study illuminates the obstacles and potential for implementing rapid tests for HIV, syphilis, and hepatitis B in antenatal care setting in Indonesia, and intervention aimed at addressing these challenges and leveraging opportunities are worth considering to enhance the implementation and coverage of triple elimination program in the country. Okay, this is just the acknowledgement of the funder of this study. And I would also like to acknowledge all the participants and stakeholders involved in this study. Thank you. I think that's all. And now I return the session to Ibu Kirana as moderator, and I welcome any questions or comments for the study. Thank you.
Okay, thank you very much to Dr. Wulandari for your presentation. Give applause to Dr. Wulandari. Okay, I want to ask to Mrs. Wardati Humaira for the coming of our General Director. Still continue or
Not
we will
yet.
stop?
No, not yet, Miss
Not
Kirana.
yet? So, okay, we will move to the third speakers, all right?
Okay, okay.
Okay, thank you so much. I want to say hello to Professor Zuraidah Nasution. Are you here, Professor? Maybe Professor Zuraida not joined yet.
Was
Oh,
joined. Was joined.
has
Yeah.
was okay. Hello, Professor Zuraida. Still in mute. Hello, Professor Dr. Zuraida Nasution. Do you hear my voice, Professor? Maybe the committee can help me to connecting to Professor Zuraida, please.
Okay, I was here.
Oh, okay.
Sorry,
No worries, Professor.
because we have another business
Okay.
meeting.
Okay, now we will move to our next speaker is Professor Dr. Engineer Zuraidah Nasution, MKes from Medan Health Polytechnic of Ministry of Health. Hello, Professor Zuraidah. Okay. I want to say, yes, I want to say congratulations to Professor Zuraidah for has just been inaugurated by the Ministry of Health of Indonesia as the Professor of Medan Health Polytechnic of the Ministry of Health Medan. Good morning, Professor. Congratulations.
Morning, yeah. Thank you.
Yes. Professor Zuraida Nasution is the professor and the lecturer in Department of Nutrition, Medan Health Polytechnic of Ministry of Health. I have noticed from Professor Zuraida Nasution curriculum vitae that she has a lot of research, which most of her studies is concerned about preventing stunting, anemia status monitoring, and also concern to mother empowerment in nutrition classes on infant nutrition status, and also uh, about best nutrition for controlling HIV/AIDS and tuberculosis among mother and children. Her working also as the reviewer journal has been recognized in the National of Indonesia. Okay, today Professor Zuraida Nasution will share her presentation for the next 20 minutes with the topic Best Nutrition for Controlling HIV/AIDS and Tuberculosis Among Mothers and Children. So get ready to be inspired, challenged, and empowered to take action. Ladies and gentlemen, please join in warmly welcoming the exceptional Professor Zuraida Nasution. To Professor Zuraida, time and place are yours.
Okay, thank you. Kirana Sihombi. Yeah.
You're welcome.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Selamat pagi. Our Honorable Deputy Minister of Health of the Republic of Indonesia, Profesor Dr. Dante Saxono Harbuono, SPD, DD, KMPD, PhD, Director of Directorate General of Health Workforce, Dr. Gigi Arianti Anaya, MKM, Director of Medan Health Polytechnic of Ministry of Health, RR Sri Arini Winarti Renawati, SKMMK, and all participants. First of all, I would like to thank you for having me in this great event. Dear all participants, for the next 15 minutes, I will present my topic, Best Nutrition for HIV and TBC in Mother and Children. I will present my topic that in Bahasa. I hope any one of you with other mother language can still follow. All right? Without further ado, let me start my presentation.
Okay.
Iya, saya pilih topik ini. Mengapa nutrisi itu penting untuk penderita HIV dan
TB, khususnya pada anak. Karena nutrisi yang memadai, yang paling penting adalah dicapai melalui makanan sehat yang seimbang. Bayi membutuhkan perhatian khusus karena kebutuhan nutrisinya meningkat. Oleh karena itu, nutrisi yang cukup untuk bayi yang terinfeksi HIV menjadi sangat penting untuk mencegah kekurangan gizi, terutama karena kebutuhan nutrisi dan ketergantungan mereka pada orang dewasa untuk perawatan. Ya, please help me to share my presentation. Ya, anak terinfeksi HIV harus secara rutin dinilai status gizinya, kemudian termasuk berat badan dan tinggi badan pada kunjungan terjadwal, terutama setelah inisiasi. Anak terinfeksi HIV yang dalam atau tidak dalam perawatan yang menunjukkan gejala memiliki kondisi yang membutuhkan peningkatan energi. Energi misalnya penderita TB, penyakit paru kronis, infeksi saluran pernafasan akut atau keganasan, atau mengalami penurunan berat badan. Ya. Selanjutnya. Kemudian untuk bayi dan anak kecil yang diketahui terinfeksi HIV, para ibu sangat dianjurkan untuk menyusui secara eksklusif, ya, memberikan ASI eksklusif selama 6 bulan dan melanjutkan menyusui sesuai rekomendasi untuk populasi umum hingga anak berusia 2 tahun dan seterusnya. Ada beberapa tantangan bagi ahli gizi, yaitu ada masalah yang tantangannya untuk bisa mengatasi masalah HIV dan TB pada anak. Ya. Dan di sini disampaikan bahwa beberapa harus mengalami masalah yang besar khususnya sehingga harus tetap diberikan upaya-upaya untuk bisa mengatasi, membuat si anak tetap kuat dan bisa memberikan perawatan sehingga tidak mengalami masalah-masalah akut lainnya. Selanjutnya, masalah yang mempengaruhi praktek pemberian makan pada bayi dan anak terinfeksi HIV di daerah miskin khususnya dengan sumber daya yang terbatas. Pengetahuan, persepsi, dan praktek ibu yang HIV positif mengenai pemberian makan pada bayi mereka tidak memadai. Ya, umumnya pengetahuan tidak memadai sehingga sejumlah besar bayi berisiko tinggi tertular HIV. Ya, hal ini.
Halo, Profesor
Ya,
Juraida.
halo.
Ya, mohon maaf karena Ibu Arianti Anaya sudah bergabung bersama kita di Zoom ini, maka presentasi Profesor kita tangguhkan sebentar ya, Profesor.
Tapi maaf kalau nanti pas saya masuk di evaluasi mungkin akan terkendala, ya, mungkin akan disampaikan yang lain. Makasih.
Baik, terima kasih, Prof. Oke, kami kembalikan ke Ibu Direktur. Kepada Ibu Arini kami persilakan.
Please unmute, Bu Arini.
Thank you. Good morning, Ibu Dirjen. Please welcome to our meeting.
Hey, good morning, Bu Arini. Welcome to Indonesia.
Thank you. Last night as I'm landing Suta. Thank you. Please welcome Ibu. Give me arahan. Give me for over to international conference this morning. Please welcome.
Okay, let me start to give a remark. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Nama Budaya. Greeting to all of us. To the Honorable Director of Health, Poltekkes Medan, guest speaker from Indonesia, and all the overseas committee participant of the seminar, ladies and gentlemen. First, let us praise God Almighty for allowing us to gather at the International Seminar of Health Poltekkes Medan. It is my pleasure to welcome you, since your attending show that you care about the HIV and tuberculosis alleviation. I also want to give the appreciate for the Health Poltekkes Medan, for the director of the Health Poltekkes Medan, and all the team for conducting this international event. I expect this conference will increase knowledge and skill for all the participants to perform comprehensively how we gains with the HIV and tuberculosis prevention and control. Ladies and gentlemen, as we know that in our data, tuberculosis and HIV are global health problems, including in Indonesia until now. Indonesia has the second rank of the TB burden in the world. It is estimated that 354 of the 100,000 population with the TB and 52 of the 100,000 population die from the TB. While that estimate that 540,000 people living with the HIV in Indonesia in 2022, and 26,000 people die due to the HIV. Women and children are affected by this disease. Urgent action is required to the end TB and HIV epidemic in 2030, as mentioned, is a sustainable development goal, a worldwide goal that has been adopted in Indonesia. Thus, the Ministry of Health of Indonesia enhanced health system. We developed a 6-pillar transformation. That is, the first is about the primary health care. Second is about the referral health care. Third, about the health resilience system. Fourth, about the health finance. Fifth, dealing with the human resources for the health. And the last is about the health technology transformation. All the transformation, we do all the transformation to develop our healthy. TB and HIV are preventable disease. Those that become one of our targets in the primary healthcare transformation. We would like start to take care from the primary healthcare transformation. TB and HIV are a subject in a community education in order to improve public knowledge for this disease prevention and control, as well as reduction stigma. Expanding disease screening also enhance early surveillance for the precaution is one of the important things for the prepare or for against the TB and the HIV in our people. Health workforce should have an important role in this primary healthcare transformation, as well as other pillar of the transformation. All the health workforce should doing the promotion and also prevention. That is an important thing since the beginning in the primary healthcare. Health workforce have a crucial responsibility for building community resilience in our people. In the health services in all levels can be ensured by the availability and adequate, and also the professional of the health workforce is executing procedures, and it is essential to how we educate and how we manage our health workforce in order to ensure the achievement of the quality standard, our health quality standard. Ladies and gentlemen, TB and HIV do not respect geographical and socio-economical boundaries, and that is the importance of the regional and the global cooperation in this area is more evident than even before. As we move forward, it is important that we continue to give a prioritize to the how we do the prevention and manage the TB and HIV since the primary in Indonesia. This require must be doing by a multi-program and also multi-sectoral and all the stakeholders, and not just only the health sector, because many things that can be have a contribute about TB and HIV. That's why we must working together with another sector such as education, agriculture, and also the urban planning. The community improvement is also necessary to build a sustainable health program. And we believe that by working together, we can create a healthier and more prosperous Indonesia. I hope this international seminar, I think this is the good theme, yeah. And I hope this seminar, we can engage each other, all the participants, and in order to increase how we do to increase the public awareness as well as enhance our cooperation regarding TB and HIV management. And I hope that this seminar, we can have a fruitful discussion. And because so many professionals as a speaker, and also all the team from the Poltekkes meet together, how we make a strategy to against or to prepare our people for this disease. I think this is the good opportunity for us, and hope all of you continue to fight against TB and HIV for better of global health, and working together is, I think, that is the good opportunity for us to against TB and HIV. Thank you. Wabillahi taufiq wa hidayat. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mom. During your activities, for take time to give attention to us.
Okay.
Thank
Thank
you
you.
for the
Have a fruitful
direction.
discussion for all the participants. Thank you.
Yeah, thank you, Mom. And there's always provide assistance for the further development Medan Polytechnic to world-class Polytechnic, Mom. Ya.
Okay. Thank you.
Ya. Selanjutnya silahkan kami kembalikan kepada pembawa acara. Terima kasih sekali di sela-sela aktivitas sudah memberikan perhatian pada kita semua. Terima kasih. Selamat melanjutkan aktivitas, Ibu.
Terima kasih Ibu Arianti Anaya. Terima kasih juga kami sampaikan kepada Ibu Direktur Poltekkes Medan, Ibu Arini. Sehat-sehat Bu di
Amin,
Jakarta,
amin.
Bu. Semoga
Amin,
sukses
amin.
semua pekerjaannya di Jakarta.
Amin, amin.
Ya, oke. We will continue again to Professor Zuraidah Nasution. Halo, Ibu Profesor.
Sorry, Miss Kirana, she has any activities. So I think you next for speaker. The next speaker.
In this session, only 3 speakers.
Oh yes,
Miss Wardati. So
enough, yes.
Yeah, it is enough
Okay.
for the presentation. So we will continue to the next question and discussion.
Yes, discussion. Okay.
Yeah. Okay. Thank you so much. So, ladies and gentlemen, if you have any questions from speaker 1 until speaker 3, I hope you can type right on the chat box, please. Thank you. Before we read the questions, I want to ask to our speakers, Dr. Wulandari. Do you hear my voice, Doctor?
Yes, Ibu Kirana.
Okay, thank you so much. I have read your presentation and I have a question to you. From your conclusion that there is there are obstacles and potential for implementing rapid HIV, syphilis, and hepatitis B testing in A and C services in Indonesia. So, what are your suggestions based on your conclusion so that we can eliminate all the obstacle from your research? Thank you.
Okay, thank you so much, Ibu Kirana, for the question. It's a very good questions. I think it's a $1 million questions, and the answer needs a whole thinking about how to improve the program to eliminate HIV, syphilis, and hepatitis B transmission from mother to child. So we can see from the study that there are huge challenges for the program, including the implementations in the field for logistical issues, human resource issues, the recording and the reporting issues, and also the whole problems around the context of the decentralized health systems. So actually, the one size fits all approach is not really probably a good strategy to solve the problems across the broad geographical areas in Indonesia, especially in the decentralized context. So the first one that we need to look is probably looking into the problems specifically for each district to see what kind of the problems that the each districts have faced, because we know that the problems might not be uniform. So looking into deeply at the district level might be the first strategy that we need to look. And the second one is really trying to leverage on the potential that we have in the decentralized system, where the district health office and the district government can have their own authority and planning to plan and implement the program. So we need to really have a good or strong connection or discussion with the local government. And third is trying to improve the coordination across sectors, because we know that a majority of maybe women in the country are seeking antenatal care not at the public health services, but at the private sectors, including the private midwives, the obstetricians, and etc. So improving coordinations between the public sectors and the private sectors is also I think a good strategy to consider. I think that's my answer for that questions. Thanks.
Okay, thank you so much. Maybe the in your place of your research in Nusa Tenggara Timur, right?
Yes,
NTT
Bali and Nusa
and Bali.
Tenggara.
How about in Java? Is same obstacle that happen to your in your observation, or maybe because of the the place, different place, so it's more more different in Java? How about
Yeah.
your
Okay.
suggestion?
Okay, so yeah, fortunately, I'm now involved in the study, similar study around the challenges in HIV, syphilis, and hepatitis B testing at antenatal care settings in West Java, in Bandung and Bogor. And I don't, maybe at this stage, uh, we are still not ready for publishing the results, but in general, we see more or less similar problems or issues in West Java compared with the one that I saw in Bali and in West Nusa Tenggara.
Okay. So maybe I think that you have explained about the policy that we can get together with our government. But as we know that the triple elimination in from Ministry of Health of Republic Indonesia has been held, but maybe what is the kekurangan ya, the lack of our government that not not doing by them. So you give a suggestion for our government. Maybe you have any suggestion, please?
Okay, thanks, Ibu Kirana, for the question again. I think it would be hard to just pointing fingers on the governments because it's not only the challenges that the national government have faced, but also in the local level. So I believe that every district have their own specific problems and resources that they need to mobilize to improve the EMTCT or PMTCT programs. But then in general, what I can see from my previous studies and the current studies that I'm involved in is how the decentralized health systems has actually complicates, if not challenging, so complicates the problems. The national government is already trying their best to provide guidelines, the regulations, even the funding supports. But then, because of the decentralized context, it really depends on the local government to really prioritize the EMTCT in their district funding. So it means that whatever the national government has done, at the end of the day, it really depends on the district health office or district government to prioritize or implement the problems in adherence to the intention of the national level. Unfortunately, as we may see from maybe other research or other studies or other health problems, we know that there are maybe more than 500 districts in our country, in Indonesia. And I believe that these 500 districts have all different capacities to plan the budget, implement the programs. So that's how then the technical supports, in addition to funding supports, is really important for the district level government.
Okay, thank you very much for your suggestion, Dr. Wulandari. We hope this is the best opportunity for us so that maybe after you publish your research and our government read your journal, your published, and there is new policies for the new policy that be a good for strengthening to eliminate the what I say chains of transmission of three infection disease, HIV, hepatitis, and syphilis that you have explained to us. Thank you so much, Dr. Wulandari. Now we will move to the participant. Have you sent your questions in the chat box, please? Or maybe you can use your raise hand in the Zoom. The committee, maybe any questions? If we want to ask Professor Zuraida, we can also type our questions from chat box, and also to Dr. Diki Budiman. Okay. I think there is no question anymore, so I will read the conclusion or the resume of this session. First, it is not enough for an HIV control program to be implemented only by health rank alone, but must also involve other sectors and society or community, especially key population. The involvement starting from prevention effort in the community to treatment, support, and treatment, so that the HIV control program this disease a public health effort as well as individual health efforts. That is the resume from Dr. Diki Budiman presentation. The second is from the resume of the Dr. Wulandari is transmission of HIV, syphilis, and hepatitis B infection from mother to child can actually be prevented with simple and effective intervention, namely early detection or screening during early pregnancy, treatment as early as possible when diagnosed, and immunization. Besides that, it is important to carry out sustainable health promotion to increase knowledge and information regarding HIV, syphilis, and hepatitis B infection. Okay, and the third from resume from Professor Zuraida. The principle of good nutrition for HIV/AIDS sufferers can be done by consuming sufficient amounts of protein, carbohydrates, fats, vitamin, and minerals, because one of the characteristics of AIDS sufferers is a lack protein energy, which can be identified by weight loss. Okay, thank you so much for all of your attention. Okay. Thank you so much for all the speakers, Dr. Diki Budiman, Dr. Wulandari, and also Professor Juraida. Ladies and gentlemen, I apologize if in this session there are still many mistakes and disadvantages. I hope we can meet again in a nice conference. Thank you to all of you that has been follow our conference today. I will return this event to our Master of Ceremony, Miss Wardati Humaira. Thank you.
Thanks, Miss Kirana. Very good performance. Okay.
Thank you so much.
Okay, happy attendees. The first session have been completed. Let's give applause to all speakers and moderators. Okay, ladies and gentlemen, we move to second session. At this session, we'll feature two speakers and three speakers too, who is Associate Professor Dr. Wan Rohani Binti Wan Taib from University of Sultan Zainal Abidin Terengganu, Malaysia, and Dr. Mansur Abdul Hamid from University of Malaysia, Sabah, and then Miss Nola. So, okay. Dr. Nola, a Holness PhD from Florida University. So this event will be guiding with our moderator, Mr. Febri Sembiring. But before that, I will also read to curriculum vitae about Mr. Febri. Yes, please share. We hope so. Already, yes. Well, Mr. Febri, born on, I don't know what, oh no, sorry. Is a lecturer of Medan Health Polytechnic of the Ministry of Health of Indonesia. Previously, he had worked as supervisor of genetic and metabolic engineering at Wilmar International Group. Is graduate of Bachelor of Science, Medan State University, and continue studying get double Master of Science at IPB University, Indonesia, and Kasetsart University, Thailand. Interesting facts about Mr. Febri. He is confident and ambitious individual. Okay. He possesses good communication abilities in terms of training and transferring the information clearly. Using effective and communicative PowerPoint, he able to work independently and in a team. He is strong analytical, oh, have leadership, and innovative person. I believe that, yes, Mr. Febri. Okay. So with we already know the description about Mr. Febri. So for Mr. Febri, please guide the event. Thank you. Please unmute by host. Okay.
Okay. Thank you, Miss Wardati Humaira, for introduction me in front of the audience. And Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Based on the instructions of the Ministry of Health, Health Polytechnic like Poltekkes Medan must be supporting the Ministry of Health policies in each respective areas. And if we see the data, Indonesia is a second rank of TB cases in the worldwide. So unfortunately, our province, North Sumatra, is a sixth rank of TB cases in Indonesia, and with 22,000 patients. Due to tuberculosis is almost exclusively airborne because it is an infection of alveolar macrophage, so it will be so easy to infect our body. Therefore, we need to do a collaboration for accelerating elimination of TB cases. And one of the solution is by joining this international conference. So I welcome you to the second international conference of Poltekkes Medan by the innovation in controlling HIV/AIDS and TB among mother and children. So I'm Febri Sembiring. It's such an honor for me to lead this session as a moderator with three incredible speakers. They are Associate Professor Wan Rohani binti Wan Toit from University of Sultan Zainal Abidin, Malaysia, Dr. Mansur from University Malaysia, Sabah, Malaysia, Nola Aholnes, PhD, and collaborated with Dr. Latisha Barfield from Florida International University, Miami. So ladies and gentlemen, before this presentation begin, let me inform you how the presentation will be going on. First, the three distinguished speakers will be invited to present the materials for about 20 minutes. And then after that, there will be a question and answer session. So if you have some question to the speaker, you can either deliver by chat or direct by raise hand. Okay, ladies and gentlemen, without further ado, I welcome the first speaker. We have Associate Professor Dr. Wan Rohani binti Wan Toib from University of Sultan Zainal Abidin. Please share the CV to the screen, please, Panitia. Okay, for the first speaker, I repeat again. For the first speaker, we have Associate Professor Dr. Wan Rohani binti Wan Toib from University of Sultan Zainal Abidin. She was graduated from University of Science Malaysia for bachelor's degree and then continued her PhD program in Otago University, New Zealand. Her research are related to human genetics, genomics, and proteomics. She is currently working as a lecturer from University of Sultan Zainal Abidin. She has published in many journals, books related to disease and genetic approach, of course. And the most recent publication of hers is HBB gene mutation in their pathological impact on HBE thalassemia in Kuala Terengganu, Malaysia, published on Diagnostic in 2023. She also achieved many awards on and another awesome experience, as you can see on the screen. So, ladies and gentlemen, take your note for this amazing presentation because maybe it's very suitable for my field right now, for my research, and maybe it would be suitable also for medical laboratory technology department and pharmacy department because we also working with this area in the Poltekkes Medan. So without further ado, I welcome you, Miss Rohani. Hi, Miss Rohani.
Assalamualaikum warahmatullahi wabarakatuh. Can you hear me?
Yes, Miss Rohani. For panitia, please give a okay. Okay, thank you.
So can I start sharing the slide or the
Yes,
panitia?
are you ready to share your presentation, Miss Rohani?
Yes, definitely. Okay. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you very much to Mr. Chairperson, Pak February. Sawadikap.
Miss.
Sawadikap.
Sawadikap. Miss Rohani. Miss Rohani, I give you 20 minutes for a presentation about haplotype SNP marker, right, in tuberculosis for genetic perspective. Okay, to Miss Rohani, time is yours.
Okay. Just honored, Sri Ibu Arini Rinawati, our Director of Medan Health Polytechnic of Ministry of Health, Ibu Ranti Anaya, the General Director of Health Workforce, the organizers, ladies and gentlemen. Alhamdulillah, praise to Allah for giving me this opportunity to share my limited knowledge on tuberculosis issues in a perspective of molecular approach. So I hope the internet line is okay because we are currently in monsoon season, which sometimes interrupt the connectivity. So I hope it goes very smoothly this morning. Okay, next slide. Okay, so the talk will cover three main aspects, which is the spread of tuberculosis itself, the role of haplotype-based SNP marker in gene mapping on how we are able to identify the genetic variants contribute to the susceptibility of individuals to TB, or might also play a protection based on the association analysis. And the third aspect I will discuss on the precision medicine based on the genetic makeup for better strategies in specific treatment. Okay, next slide. So TB, as you all know, that TB is caused by a bacteria called Mycobacterium tuberculosis, which remains to be one of the top 10 causes of death in the world, with approximately 5 to 10% latent tuberculosis infection individuals. And with this, around 90 to 95% individuals would develop active tuberculosis infection. And according to the WHO report, about 10.4 million new cases and 1.3 million deaths occurs in the 2016. So this latent TB, or what we call as primary TB infection, is a state when the persistent host immune response to stimulation by this Mycobacterium antigen is sustained without any evidence of clinically manifested active TB. So as many as 10% of people with latent TB will go on to develop progressive TB in the near future, what we call as TB reactivation. And the risk is significantly higher in the presence of these predisposing factors such as co-infection with the HIV. Okay, next slide. So according to the WHO 2021, approximately 1/4 of the human population is estimated to have exposed to Mycobacterium tuberculosis and carries this infection in its latent form. So the 8th country that ranked first to 8th in terms of number of cases is that counted for 2/3 of global cases, with the most TB in the WHO regions of Southeast Asia with 45%. So Africa is about 23% and Western Pacific about 80%, with smaller shares in the Eastern Mediterranean, Americas and Europe. Okay, next slide. A bit on the treatment of TB, it's very difficult and relies on long-course regimens of chemotherapy, whereas about 5% of TB cases are multi-drug resistant. That is the limitations of the treatment so far. And the most widely used vaccine to prevent TB is BCG, which has been used for almost 500 years ago. But the effectiveness of vaccination is limited to the prevention of primary TB among children. So the etiological mechanism of TB unclear at the moment, which hinders the development of effective strategies for the treatment or prevention of TB disease. So normal macrophage function and T helper 1 cellular immunity are very critical to contain this MTB infection, but are insufficient to clear this bacteria. So around 90% of MTB infection will become latent TB infection, and it will remain dormant in granulomas in the tissue for decades. So adaptive T helper 1 immunity induced by this BCG vaccination is not effective to prevent latent TB activation, so which involve a complicated T helper 2 and 1 immunity, whereas the molecular mechanism are mostly unknown. So this is what we're going to discuss on the molecular aspect. So by this schematic diagram showing that immune response elicited after the BCG vaccination specific effects for the MTB. So once the BCG vaccine is injected intracutaneously, monocyte macrophages, the dendritic cells recognize this BCG at the vaccination site and form a strong immune response. So the cell wall or other components of BCG that binds to different ligands will upregulate co-stimulatory molecules of stimulated cell and activate this anti-TB innate immune response. So these be activated dendritic cells migrate to the lymph nodes to activate the mycobacterial specific CD4 and CD8 T cells, which is T helper and cytotoxic with the T helper 1 profile, and subsequently induce the secretions of this high level of cytokines such as interferon, gamma, and granzyme. And at the same time, these B cells respond to BCG antigen, which leads to this production of memory cells, plasma cells, and also antigen-specific antibodies. Okay, next slide. So a human genetic study is indispensable approach to understand the molecular basis of common disease. Numerous efforts were made to screen the human genome for TB susceptibility by linkage mapping and also by these association studies in this population genetics. A genome-wide association study needs to genotype nearly 1 million genetic markers to cover the whole genome that reveals the associations of genetic factor with susceptibility or resistance to TB. And a large number of candidate-based association study of TB were conducted to examine the association of predicted functional DNA variation that what we call as single nucleotide polymorphism or SNP in this candidate gene. So let me give a brief introduction what is SNP or SNP, in which is encompasses with the gene structure extending from DNA strand that forming this chromosome from nucleus of the cells. So different individuals may have different SNP, which has susceptibility to the common disease, and the diversity of genetic susceptibility to common disease in human population enable researchers to understand the molecular mechanism of common disease by this genetic approach. So this schematic diagram, as you see, the column represent the genetic variation or the SNP within each individualized allele G. The second column is allele A, represent from each SNP. So that makes different from each individuals to other individuals. So as you can see that in column row number 4 is a substitution of allele A to G. If you go up to the row number 12, there is substitutions of G to T, and then next is on the row number 15, substitutions of adenosine to thymine is A to T. So basically, the substitution GTT is the minor allele, where it's a very it's a rare allele that might contribute to the disease pathogenesis. And the combinations of allele from each SNP is called haplotypes, refers to the sequence in the row. So this might give a risk to certain disease by estimating the odds ratio in association studies. So next slide. So this is haplotypes, haplotype tagging SNP. So we can estimate the frequency of haplotype in one population in determining the common risk of that particular haplotype in predisposing to certain disease. So having to know that the susceptibility haplotype-based SNP marker will tailor the specific regime of treatment based on the genetic profile in this precision medicine. So for example, in this haplotype 1, it is estimated with 35% of frequency in the population. Next slide. So this slide is a genome-wide scanning, where how we are able to identify potential putative targeted gene and SNP in the disease. So this can be performed by this scanning, where the technology can screen hundreds to thousands of SNP by comparing the genetic profile in disease to normal subjects. So this is one study conducted by Zhang et al. 2018 in identifying susceptibility loci for TB using 3 stages of GWAS of TB in across Han Chinese population. So they conducted this genome-wide genotyping of 2,112 subjects using Affymetrix axiom CHP array. So from these regional association plots of loci associated with TB, there were 2 SNPs with highly associated with TB, which is assigned as RS1243, the upper plot, which is located on the chromosome 14. And then we have another RS166, which is located on the chromosome 20. So genotype and imputed SNPs are shown with a circle and cross symbol, that all the associated SNP in the TB. So SNPs are shown in different color based on their linkage disequilibrium with the marker SNP, which were established based on 1,000 genome Asian data. So the underneath is the reflecting the dedicated SNP. So we know that the SNP belongs to what genes. So in the table side is the combined analysis of that 2 SNP, RS124, that has been recognized to be located in ESRBP gene, and the other one, RS611 of TGM6 gene, were genome-wide associated with this TB. So both SNP showed significantly in all 3 data sets and were consistent across the set. So the most significant signal was observed at RS124. You can see the p-value for the combined is 1.72, minus 10, 10 at times minus 11 with the odd ratio 1.277. And the LA frequency for risk LA is A, so which is range from 0.261 to 0.288 in the 3 stages. And for the second significant signal was observed at RS SID11 with a p-value 2.37 times 10 minus 11 with odd ratio 1.339, and the risk LA is C. Okay, so this in that SNP and most of the link variant, the R square is more than 0.2. So this is predicted to have putative regulatory function. So from their study, RS166 regulate the expression of the TGM6 gene and is associated with the severity of TB by generating TGM6 deficient mice, where they did an in vivo study in animals. So they demonstrated that TGM6 gene protect mice from MTB infection. So taking together these findings provide shed on the genetic etiology and pathogenesis of tuberculosis. So next slide. So this is another study conducted by Borrero in 2006, where they identified 2 variants located in the CD209, which encodes this disease sign, which is located in the promoter region. So there are 2 variants from this, which is 871 and 336. Okay, so which exhibited the frequency distribution significantly distorted between TB patient with the control across South African cohort. So for the 871 variant, the genotype of GG, which is homozygous G, and the heterozygous with the GA were less frequently observed in cases compared to the control group. You can see between case and control groups. And for the 336 variant genotypes, homozygous G and also heterozygous GA were more frequent in cases control than the controls. So this observation suggests that the alleles of this variant, 871 of LA without ratio 1.85, and variant 336 with the LAG increase the risk of developing TB in the South African cohort. Okay, next slide. So this is the hepatotype association analysis, where we use the chi-square test reveal these global distributions of hepatotype frequency was significantly different between cases and control. So one hepatotype, hepatotype 3, turns out to be the main hepatotype responsible for such distorted frequency distribution. So this hepatotype, which contain both variant 871 of LAG and also a combination with the LAA from the variant 336 was, and this combination was found to be strongly associated with the control group. So with a p-value 1.6 times 10 minus 3 or ratio 1.7. Okay, next slide. So based on the association analysis that we just saw in the single association and also in the hepatotype analysis, which showing that the association of this sign with the TB, dendritic cells play a crucial role in defense against pathogens. So invading pathogens are recognized by this toll-like receptor. As you can see that that's a receptor on the cells, and the receptors such as C-type leptin expressed on the surface of dendritic cells. However, it is becoming evident that some pathogens, including viruses such as HIV-1 and non-viral pathogens like Mycobacterium tuberculosis cells, subdivert this dendritic cell function to escape immune surveillance by targeting this C-type leptin disease sign, which is the dendritic cell specific intracellular essential molecule grabbing non-integrin. So This pathogen misuse this disease sign by distinct mechanism that either they can circumvent this antigen processing or alter this toll-like receptor mediated signaling, skewing this T cell response. So this implies that adaptations of pathogens to target disease sign might support this pathogen survivals. Okay, next slide. So this is another study by Liu et al. In 2021 in Chinese Han's population, where they did a stratified analysis showing that there are two SNP, okay, RS273 for the homozygous G of CCR5 gene, significantly increased susceptibility to pulmonary TB in the recessive model. You can see that the odds ratio is 2.382, whereas another SNP, RS1799, with homozygous A, was associated with susceptibility to pulmonary TB as well, with the odds ratio 1.678. So, but not with the extrapulmonary TB and TB recurrence. Okay, next slide on the hepatitis. Okay, the extended study on the hepatitis itself. So this is constructed with the major alleles of the 8 SNPs in the CCR5 promoter gene, okay, which exhibited extraordinary increased risk of susceptibility to TB and pulmonary TB with a p-value 6.33 times 10 minus 11, with the most highly significant odds ratio 24.887. Okay, this is projected from hepatitis 5, hepatitis with other risk hepatitis in TB patient presented. You can see here hepatitis 1, 5, hepatitis 7, hepatitis 10, all give risk in TB patients. Meanwhile, risk hepatitis in pulmonary TB also observed in hepatitis 5, hepatitis 7, hepatitis 10, and also 11. And there's one protective hepatitis actually in hepatitis 1. You can see based on the odds ratio. And meanwhile, hepatitis 5 also remain to confer a risk in extrapulmonary TB as well. So this is quite astounding results projecting the role of CCR5 gene in TB pathogenesis. So next slide. So this CCR5 has been reported to play an important role in immune response against Mycobacterium tuberculosis by regulating and activating the recruitment of macrophages and further activations of the T cells. So there will be a T regulatory suppression mechanism, which includes several steps, various ways. One of them is by acting as a sink for interleukin-2 due to constructive high expressions of interleukin-2 receptor, and thus it can deprive these effective T cells of the crucial cytokine. And the second way is by secretions of immune suppressive cytokine. You can see involving interleukin-10, TGF-beta, interleukin-35, and third way can be through the granzyme beta dependent killing of the target cells. And the fourth way is by inhibit the signaling through binding of CTLA4 on the Tregs and CD80 and 86 on dendritic cells. And this can reverse the signaling by this interaction leading to these elevated levels of IDO, which is endolemin. So this eventually can deplete or reduce the tryptophan and stuff the effector T cells. So, and the fifth way is through the binding of the LAG-3 MHC2 molecules on dendritic cells, which cause reduction in antigen presentation. And then the sixth is the suppression due to interactions of PD1, which is a programmed cell death one, on T regulatory and also on the target cells. And several ways it can be through extracellular adenosine generated from this ATP in processed by cell surface on the CD39 and also CD73, which interacts with this adenosine A2A receptor on effector T cells and suppress the function by increasing the CAMP levels. And the last ways can be through this chemokine ligand 3 and also CCL4, which is secreted by this tuberoregulatory and binds to this CCR5, which is the main targets in the study on effector cell, triggering their migrations and also subsequent suppressions of these T cells. Okay, this is a bit on molecular and mechanism. So next slide.
Excuse me, Miss Rohani.
Yes.
You have only 5 minutes left to present your presentation.
Inshallah, coming to it. So
Okay,
for the
thank you.
last for the last 50 years, management of patients with TB has followed a standardized management approach. So this standardization neglects the variation in human susceptibility to infection, immune response, pharmacokinetics of drugs, and individuals' durations of treatment, which is needed to achieve the relapse-free cure. So a package of this precision medicine guided therapy that has the prospect to drive this clinical management decision based on both host immunity and also from the mycobacterium strain genetic as well. So recently, important scientific discoveries and technological advances have been achieved to provide a perspective for individuals rather than standardized management of patients with TB. Next slide. So this is going to be the last slide. So in the future, TB patient care may be individualized in at least 4 areas. One is might be coming from the next generation sequencing of mycobacterium itself. And it can predict drug susceptibility in the first week of diagnosis. So this can tailor-made treatment based on the mycobacteria genotypes. Second can be apply to the host immunity as well, as we have seen the role of the gene and protein, the involvement of the cytokine as well can be detrimentarily suppressed and need augmenting, or can be aberrant that need to be suppressed. Another form of host genetic variability that may be specifically or addressed by immune-based intervention. And the third one, individualized drug concentration that can guide my antimicrobial dosing. And the fourth way is through the biomarkers identification that can predict relapse pre-cure that can guide durations of required therapeutics, which I introduced, emphasize the role of haplotype-based SNP marker in the identifications of putative gene in the predisposing to tuberculosis. Okay, next slide. So with that, I thank you. So I welcome a research collaboration in potential molecular study in TB from the rest of the floor. And the global issue need to be tackled with a good research finding towards community awareness and implementations to the government. Thank you.
Thank
you,
you,
Pak
Miss.
Budi.
Thank you, Miss Rohani. Like you said that you are waiting for a collaboration with maybe with Poltekkes Medan
Yes, inshallah.
someday.
Yeah, it will be good.
So is it
Come here
possible
soon.
for us to visit your laboratory in Malaysia?
Oh, definitely. You're almost welcome to come here. So
Okay, we will.
good, I know you have a background in microbiology, so
Thank you.
I really welcome.
Thank you. Thank you, Miss Rohani. Okay. We're waiting for a question. We go to the next to the next speaker. Thank you, Ms. Rohani, for giving us such an informative and interesting presentation, especially for me. I get many insight the way I start my research if I want to start research like what you did. Okay. And also maybe it would be a note for Poltekkes Medan that can be starting to do a research about exploring disease from other perspective in terms of genetic perspective, right? Because I guess I consider that genetic approach is so powerful to overcome many problems related to the health sector, right?
Yes. Because I did various genetic approach in different diseases like cancer, breast cancer, brain tumor, thalassemia,
Thalassemia, yeah, I read your
yes,
CV.
gout, arthritis, and not only based on the hepatotype SNP marker, but also transcriptomic profiling, and also functional studies on the silencing knockout gene as well by silence through the microRNA. So I welcome most of you. We can collaborate in terms of research.
Thank you, Miss Rohani. Okay, ladies and gentlemen, after we got a lot of information from Miss Wan Rohani around about polymorphism in several marker of human genome and their association in the risk of tuberculosis, we go to the next speaker for the second speaker. Thank you, Miss Rohani. Waiting for a question and answer session. Okay, we go to the second speaker. Please committee share his CV to the screen. Mr. Mansur Abdul Hamid.
Oh, sorry. Hello everyone. Assalamualaikum
Halo.
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for your coming, Mister.
Yes.
Okay, and the second speaker is Mr. Mansur Abdul Hamid. Mr. Mansur is a senior lecturer at School of Food Science and Nutrition from University Malaysia Sabah, Malaysia, and he has received his bachelor's and master's degree in the same faculty, Faculty of Science and Technology, University Putra Malaysia, and taken his PhD program at University Kebangsaan Malaysia or the National University of Malaysia. And he currently published about analysis of the quality of broccoli leaf powder treated by blanching and drying, published in International Journal of Agriculture and Business in 2022, and other related publication as you can see on the screen. He also achieved many works, and one of them was gold medal for multiple kitchen cleaning tools from banana waste in Pereka 2022, and other awesome experience from Mr. Mansur. And Mr. Mansur has often been the keynote speaker for seminar and public lectures held by Indonesia institutions, including Poltekkes Kemenkes Medan. Mr. Mansur regularly, maybe I don't know, maybe Mr. Mansur frequently was invited by jurusan Gizi Poltekkes Kemenkes Medan for a expert lecture. Is it true, Mr. Mansur?
Yes. I think we already done several times for the invited lecture for that.
Okay.
Almost every year.
Oh, okay. Almost every semester or year?
I think household, but most probably every year. I will either online or offline. I got that because I also have collaboration research. Inshallah will be carried out start by next year.
With Poltekkes Medan?
Yes.
Okay. Okay. Okay, Mr. Mansur. So I consider Mr. Mansur is able to speak bahasa, right?
Yes.
Because you already collaborated with Poltekkes Medan, so you have to be able to speak bahasa. So is it possible if the audience deliver the question using bahasa, Mr. Mansur?
Yes, sure. I can understand.
Okay. Okay, and to Mr. Mansur, we please you take 20 minutes to deliver your presentation about food habits and the potential of functional foods intake for HIV and TB patients. So to Mr. Mansur, time is yours.
Okay, can hear my slide?
Yes, Mister.
Okay, I hope it worked. Is it? Okay, fine. Okay, Assalamualaikum warahmatullahi taala wabarakatuh. And in my place already afternoon, so over there for sure there's no it's not performed zuhur yet, but my place already past 30 minutes. Okay, so I will proceed. I directly proceed with my title. Okay, for this conference. Okay, by the way, thanks for inviting me as part of this conference, okay, especially to Ibu RR Sri Aryani, our director, right, of Poltekkes, and of course the keynote speakers and invited speakers as well, and other participants for this conference. Okay, so I'm proceed with my title. Okay, the potential of innovative foods for diseases. Okay, as already explained by our earlier speakers. Okay, talk about maybe they are focused more on the disease. Okay, then we focus on the among mothers and children that I can put their in non-cern population group actually. Okay, might be they especially for children. Okay, so since this my table content, but most of the content or maybe the topic already covered, okay, by our early speakers. So I just proceed directly to my topic. Okay. Okay, this already highlight maybe okay, very simple one, meaning that the HIV, okay, the virus and the bacteria, okay, the mycobacterium, okay, this the cause of the AIDS and the TB, okay, disease problem, okay. So I straightforward go to the, although might be already mentioned by Prof. Zuraida just now, but just want to highlight that when we already diagnosed, okay, have this disease, okay, most maybe the major treatment supposed to be the medicine, okay, but we have a supportive program which is the nutritional therapy, okay, whereby we need to have a balanced and healthy food, okay, in our body system. Okay, come to preventing for the TB disease. Suppose we have a few options related with the food, okay, which is high rich food, okay, protein rich, and then the whole grain, and then of course healthy fat, meaning have high unsaturated fatty acid. Okay, I think this the nutrition part already I think covered most progressively by our earlier speakers, Prof. Zuraida. Then I directly go to our maybe food habit. Okay, over here mentioned that talk about healthy diet. We must have adequate, moderate, balanced, and varied. Okay, this meaning that we need to identify, okay, and or maybe modify the food. Okay, whereby we need to make the target group, especially children, for instance, they really love food with more attractive. Okay, so this what we are try to put in consideration to need to prepare the innovative food. Okay, and then of course we need to follow the food safety, okay, rules, which is more hygiene, okay, good hand washing practice, okay, and of course if we have problems, okay, we need to seek help from doctor and nutritional counseling. Okay, talk about the controlling the disease, okay, the AIDS and TB diseases. Okay, as mentioned, we can divide into several stages. Okay, so of course we need to identify what the main support, okay, to 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 uh, to solve the problems, okay, such as for the awareness, okay, and then second, cure and recovery, and for last, I think the sustainable and long life, okay, the good long life start, okay. So of course, the first talk about maybe the health, okay, lifestyle, and then talk about the cure or recovery. The main supposed to be the medicine, okay, as mentioned, we must have the ART, and another one for the TB, we have I and H. Okay, but supportive diet also really important. Okay, about the talk about the good health diet, excellent food habit. Okay, and then we are also talking about the innovative food product. Okay, talk about the food innovation since this is my field of my study. Okay, so maybe we need to slightly maybe clarify on the food innovation, which is to develop new food processes, okay, product or service. Okay, so meaning that there's a huge of or maybe the wide, okay, definition on this, okay, that gives significant contribute to the industry productivity and market choice, or in our case maybe for the passion. Okay, then the innovation in food aim to improve the consumer life, okay, which is talk about the passion just now, and efficiency of the food business operation. Okay, this one might be more to logistic problem. Okay, as mentioned by our first speaker. Okay, normally maybe the conjunction. Okay, maybe we have a difficulty, especially for the remote area. Okay, whereby we can maybe give the deliver our medicine or maybe the foods, okay, and then to produce a healthier and a newer option for consumers. Okay, this might be the I think the good food innovation talk about, and then also product with healthier and unconventional, okay, ingredient, okay, that provide more benefit, okay, than the use raw materials. Okay, and then we are talking about focus to finding more way to make food, okay, service and manufacturing more accurate, safe, and sustainable. And the last, to incorporating technology to make processes more effective and less prone to mistake. Okay, talk about this the food innovation, and normally we also link or quite impressive deal with the functional food. Okay, where the food that provide health benefit, okay, beyond basic nutrition. Okay, that normally we also call as a novel food, okay, that has been formulated so that they contain sustain or live microorganism. Okay, most probably we are talking about prebiotic, probiotic, okay, that have a possible health enhancing or disease preventing value. Okay, this functional food, okay, also can be put under added ingredient, may include nutrient, dietary fiber, phytochemical, and other substance or probiotic. Okay, these what we categorize as a functional food. Okay, patient with disease include these AIDS and TB were lack of appetite. Okay, so they must be providing healthier and more nutritious food in every bite. And most of these patients have drastic, okay, in body weight loss and without energy. So we have several type of cases, okay, where we need to supply, okay, protein or energy, okay, supplement in their food supply. Okay, we have several study case, okay, already done. Okay, and then bioactive food component, okay, whereby we also do some case study, okay, then we need to identify the bioactive component, okay, that are also important in our functional food. Okay, I talk about maybe the probiotic and prebiotic. Okay, this normally the living cells, yeah, the microorganism, okay, that are really involved in the improving the health status of our patient. And then most of this group of passion, yeah, not even for the AIDS or the TB, yeah, only, but I think most of anyone that already maybe diagnosed have a whatever disease, normally they are like in certain micronutrients. Okay, for this kind of HIV, okay, we consider that this all the micronutrient, which is vitamin A, B, iron, and zinc, are really important to improve their health. Okay, maybe this is the good photo, much easier to understand that we have several food ingredient or maybe supply in our nearby surrounding us that actually high in nutrient that really important for this patient. Okay, but somehow we know that since they have a lack appetite on the food intake, so might be we are as a food technologies need to give a innovate food product whereby we give them every bite of food containing complete and balanced food with the good nutrient. Okay, so we know, as mentioned just now, we like the depression normally weight loss very drastic. So we need to supply them with a high calorie food. Okay, vitamins, mineral supplement if recommended. This one need to get advice from doctor or nutritionist. Okay, probiotic, antioxidant, and vitamins. Okay, so I think this mechanism, okay, whereby they can gains, okay, TB, okay, I just maybe just okay proceed. Allicin normally from garlic, okay, and as we know, the fresh one, okay, contain high allicin, but we also can consume the black garlic or fermented garlic, okay, that have a better amount of antioxidant as compared to the fresh one. Okay, so innovative food production stage, okay, totally depend on the our target population, especially mothers and the children. Okay, so most probably we must design the food, okay, that familiar to the group. Okay, it's not maybe an unknown food. Okay, so maybe they're scary to maybe try the food. Okay, must be attractive, convenient to use, and since we know that they are maybe less in energy, for example, so must be convenient and cheaper. Okay, especially for the economic level. Okay, and then for the children, we must also identify the food must be suitable to target group, which is maybe in liquid form, syrup, or maybe candy also. Okay, attractive in color and appearance, easily consumed, cheaper, and good taste. These are maybe the good preference for our target group. Okay, and then step of the functional food innovation process. Okay, this also I practice for many step of in food innovation, not necessary for the our group that may be diagnosed with some disease, but it also possible when we apply for the community surround us. Okay, so the first identify the most common food, okay, and then search for the most available raw material used in their diet. Okay, review the functional properties of the food ingredients, choose the most suitable food based on our first through screening, okay, and then formulate the product properly based on sensory accessibility, help claim by proper analysis and clinical tests, lastly, its stability, okay, throughout the storage period. Okay, so important in component in food such as food, actually, we must have a good and sustained and of course available raw material source. And then we have a good production and processing group. And then the last, of course, we also need to do promotion and marketing strategy. So over here, I show that there's a lot of, I think, common food that available around us. Then there's a lot of nutrient that can be supplied by all the food ingredients. Okay. And then talk about food ingredient also. We must think about the safety level since we're talking about the patient. Okay, so we must ensure that we have a sufficient treatment. Okay, normally by heat treatment. Okay, minimize the treatment other treatment because most of the micronutrient, especially of a vitamin. Okay, which is water soluble. Okay, so through washing, okay, after cutting, for example, okay, maybe they will diffuse during the washing treatment, okay, or maybe heat treatment, overheat treatment, maybe it will be denature or maybe spoil the nutrient, okay, and then proper handling and storage, and the last must have the quality control checking throughout the process when we develop the food innovative product. Okay, so this example normally I apply for the drying treatment. Okay, normally I did some study on the drying process. Okay, several drying process. We also need to consider about the remote area. Okay, talk about maybe cabinet dryer or maybe electricity. Maybe they don't have on this. So we must have give them the right option. Okay, so the indirect, okay, sun drying, okay, uh, treatment is the good, okay, option to maintain the nutrient content. Okay, and then for sure we can get the better color of our dried product. Okay, another one might be this the treatment we turn into dry or in powder form, and then we develop our syrup. Okay, much better and efficient in terms of their formulation. Okay, then we get the standard. Okay, as compared to maybe we just marinate it or maybe we just simmering the piece of our herbs. Okay, and then we are also talking about the innovative noodles. Okay, by adding the vegetables, for instance. Okay, because we know that most of the children, okay, they don't really like to eat the vegetable. Okay, so we are incorporate in the food production. Okay, to improve their fiber. Okay, and the mineral content. Okay, by adding the incorporate the vegetables in the noodle making. Okay, and I also want to highlight over here that we normally didn't utilize much on our byproduct agriculture industry. Okay, whereby for example, our jackfruit, we only maybe focus on the flesh. Okay, produce several type of food. Okay, processed food like jam, cordial, candy, etc. Okay, but how about the peel, seed, ring? Okay, all these normally underutilized and normally just maybe throw away. Okay, or allow to decompose. Okay, to produce maybe the natural organic fertilizer. But why not we enhance it? Okay, to produce better quality of food product because they have a lot of nutrient, okay, normally in this underutilized part of product. Okay, this what I did mention, okay, because I summarize it. And then okay, I put over here about the ring and the jackfruit. Okay, whereby this one I think there's no problem with the flesh. So from the seed and the ring, okay, we are already developed, okay, the plant-based meat analog. Okay, this one suitable for vegan, and of course, there's no much better in terms of healthy saturated fat or maybe good fat. Okay, because we don't use the fat. Okay, tallow or maybe the lard from the animal cells. Okay, so we are trying to reduce the saturated fat in our production. Okay, and of course we also use this okara byproduct from the soya milk for extraction. So we utilize it, okay, to produce this kind of the analog meat patty. Yeah? Okay, for the mangoes, okay, we focus on the seed also, okay, because we not problem with the flesh. So we're talking about the seed and the the peel, okay, and then we turn into flour also, and then we incorporate to make a noodle also. So by get the best formulation, we can show that the product contain high nutrient as compared to normal noodle. Okay, and then this also we produce the instant noodle. Okay, because we also know that the instant maybe because of our lifestyle. Okay, we need to do faster everything. So this also part of our research. And then
Excuse me,
yeah,
Mister.
yeah.
You only have 5 minutes to
Okay,
get
okay,
your
okay, okay.
presentation.
Yeah. Okay, thank you. Okay, and then Vikaya actually the combination normally instant vegetable spread. Okay, we use no egg, no santan or coconut milk. Okay, so we produce more healthy food product. Okay, this also okay the sweet potato. I think we can get as much in surrounding us. Okay. Uh, this one also healthy drink, okay, low calorie chocolate, and then this one compact with energy. We produce energy bar, okay, from seaweed, okay, and then the core of pineapples, and this one the used grated coconut, okay. So as a conclusion, okay, I wrap up my presentation. Okay, so nutrition plays important role for both of these passion category or groups. Okay, take the treatment and practice the living style and food habits very effective for this passion. Okay, to having a quality life. Okay, and then functional food have a potential to provide more benefit for this group of passion. Okay, consuming a balanced diet that helps support the immune systems and promote overall health to both of these group of passion. Okay, active compound in food possess antioxidative and immunomodulatory properties which contribute to their ability to migrate the pathological impact of HIV and these TB bacteria. Okay, and the last, the food innovation are the good option for the patient since they lack in habitat and need the fast recovery from their normal life. Okay, with that, thank you very much for your attention. I pass back to the moderator. Thank you very much.
Thank you, Mr. Mansur, for the amazing presentation, giving us such an informative and interesting presentation. So I consider that understanding the significance of food habits and exploring the potential of incorporating functional foods into a diets of individual with HIV and TB is most important for comprehensive health strategies. And I continue, by the right dietary choice will be positively impact to the health, immune response, and overall quality of life of for the patients with HIV and TB. Maybe this strategy will be one of the concrete community services that we can do as a lecture in the North Sumatra. Thank you, Mr. Mansur. And we'll continue to the last, not the least speaker, the third speaker from Florida University. Hello. Hi, Miss Nola. Hi, Miss Nola.
Hello.
Hello. Panitia, bisa dipin panitia? We are waiting for your CV to share on the screen, Miss Nola.
Yes, you have it. You want to share it?
Yeah. While waiting for a committee to share it.
Okay. Well, good night, good morning.
Okay, maybe in Florida night, right? But in Indonesia, it's still afternoon. Okay. Good morning. And for the third, we continue to the last speaker. For the third speaker, we have Miss Nola Holness PhD. She has received her bachelor's and master science in nursing at Florida International University, Miami, and continued her PhD program in Florida International University, Miami. She is currently working as a lecturer in Florida International University, from Miami, right? She has published in many journals, and one of them is Perception of Patient and Staff, and as well as Community on the Role and Function of Certified Nurse Midwives, published on the program book of the International Confederation of Midwives. She also achieved many awards and other awesome experience and one of them, she achieved an award for Worldwide Leader in Healthcare as a top nurse educator in Miami, Florida in 2016. Wow, amazing. Okay. And then Miss Nola, we hope that Miss Nola doesn't get tired of waiting for us. For waiting for your presentation. I hope you're still on fire to present your presentation.
Yes.
Okay. Thank you for coming, Miss Nola, in this international conference. And to Miss Nola, we please you to take 20 minutes to deliver your presentation about HIV or HIV/AIDS in pregnancy. And this presentation was collaborated with Dr. Latisha Barfield, right?
Yes.
Yes.
So together we'll present.
Yeah. She is also a clinical assistant professor at Florida International University since 2017. And then she also a community member for an international PhD student in Nigeria. So to Miss Nola and your friend, time is yours.
Okay, thank you. If you will share the slide on the position statement.
Ya, Miss Nola. Tolong di-share screen PPT-nya, Bapak Ibu.
But I want to say, while you're bringing up the screen, thank you for having us. It's 12:14 in the morning here in Florida for us. So yes, we are tired. A long day, but it's a
Thank
pleasure.
you, Miss Nola.
But it's a pleasure to be here. So I'll just keep talking until the screen comes up. So in June of 2023, I came to Bali to attend the International Confederation of Midwives Congress. And there I met Nurimati, Miss Nurimati, and she invited me to come to the conference today. So when I got the invitation, I said, let me bring along my colleague, Dr. Barfield, as well. There's another presentation. Can you pull that up first? The position statement. So we're both nurse midwives in America. So we wanted to talk on HIV and pregnancy. I wanted you to be aware of how the American College of Nurse Midwives looks at HIV in women who are pregnant. So if we could pull that up first, and then we will go into this. I don't know, maybe I can share the screen, can I? Am I able,
Yes,
Mr. February,
yes.
Am I able to share my screen? All right,
Yes,
I'm going to pull, perfect. So let me pull this up. Can you see it?
Yes, Miss Nola.
Perfect. All right. So I want the audience to be aware that the American College of Nurse Midwife puts out statements each year or over a period of time that relates to the issues that concern pregnant women. One of them is the HIV and AIDS situation with pregnant women. So the college supports every effort to prevent and treat human immunodeficiency disease, HIV, and acquired immunodeficiency syndrome, AIDS, through prevention strategies, screening, early diagnosis, and treatment that should be accessible to all who request or require these treatments. So these are the recommendations that are made in America regarding the Center for Disease Control as it relates to HIV in pregnancy, as well as those who are not pregnant. So here, all individuals should be counseled about HIV risk behavior, about the risk reduction and prevention strategies, especially including the PrEP care for individuals who are high risk to contract HIV. Individuals who are 13 to 64 should receive voluntary HIV testing as a routine part of their health care. When they come in to see the physician or their healthcare provider, they should be offered the HIV testing. Women who are living with HIV should be counseled about the risks and the benefits of the therapy, the antiretroviral therapy, during their prenatal, perinatal, and neonatal periods, and should be offered appropriate treatment regimen. When you're pregnant, HIV testing should become a routine part of your care. And you can volunteer to opt out, meaning you tell the provider, I don't want the HIV test, but it must be offered to every pregnant woman. Women should be notified that the HIV screening is recommended for all pregnant women and that it's a routine part of her prenatal care. All women and their partners who are living with HIV should be counseled in a non-directive manner regarding their reproductive choices, to include education about the different kinds of treatments that are available and the use of condoms and viral suppression by those treatments. These HIV preventive measures should be a part of the counseling, both for conception and contraception, to reduce the risk for HIV transmission between HIV serodeficient different couples and to meet their family planning needs. So one person may be positive, the other person may not be, so they require those intervention and counseling. Pregnant women who are living with HIV should receive prenatal and perinatal care that minimizes the risk for vertical transmission, and we're going to talk about that a little bit more. They should be getting the antiretroviral therapy, and they should be counseled about the individual risks and benefits of vaginal birth versus a cesarean section regarding the risk for vertical transmission to the baby. A woman's decision about the type of birth that she's going to want, that decision should be respected. Women who are living with HIV and have access to adequate and safe formula supplies should be advised to avoid breastfeeding. So these are the positions that are taken in America. If you have safe formula supplies, you're advised not to breastfeed to, again, reduce the chance of transmission to your baby. Now, here we talk about certified nurse midwives and midwives, the CMs, because we have two types. You have those who are nurses already and then became midwives, and those who are direct midwives. Dr. Barfield and I, we are both nurses and midwives. So, nurse midwives, we should be knowledgeable about the laws and the national regulations that require compliance regarding HIV testing. We should be telling our patients about the informed consents, about privacy, about confidentiality of the testing results. The public and the private policies should assure that individuals who are living with HIV are not denied access to healthcare, to medications, to life insurance, or employment based on their HIV status. The different states in America should adopt comprehensive legislation that provides access to voluntary testing options, including same-day results, and then give the health officials and the providers adequate mechanism to track the epidemic and then provide access to care for all HIV or AIDS-affected individuals. We are aware, though, that despite ongoing efforts aimed at prevention, women continue to make up about 1/4 of the HIV cases. So we do believe that women should be viewed as a high-risk group where HIV is concerned and be treated as such. Heterosexual transmission is the primary source of infection for women. And as we're going to see later, women of color are disproportionately affected. So our college that governs our regulations and our legislations for nurse midwives, they endorse what the Centers for Disease Control recommend, that again, we should be testing and using universal screening for HIV. So that's where the position that's taken in America. We believe that the pre-exposure prophylaxis called PrEP should be available and recommended for those who are considered HIV, those who are HIV negative, but are high risk for the infection. All women and their partners have a right to the information. Women without HIV who wants to conceive a child with a man who is HIV positive should be counseled about the possibility of in vitro fertilization, so that there's no transmission directly from the man to this woman who's trying to have a baby. Testing should be done routinely early in the pregnancy and repeat, this is very, very important, and repeated during the 3rd trimester if there's any additional risk. If HIV testing is declined early, then the test should be offered again in the 3rd trimester. Rapid voluntary testing should be done during labor if her status is unknown. HIV testing of infants whose mothers were not tested during pregnancy is encouraged. Evidence to date suggests that for select women with higher viral loads, a cesarean section prior to labor will reduce the risk of vertical transmission. So basic knowledge about HIV prevention, HIV screening, counseling and treatment should be included in all midwifery education program. And I hope that this is the same in Indonesia. Model comprehensive multidisciplinary programs should address the complex medical, emotional, and social needs of individuals who are living with HIV or who have AIDS. And these programs should be promoted. So this is the stand that we have taken as a country and as a midwifery group on HIV among those who are pregnant. So now we can share. I can share it from here as well. We can share the other screen, and I'll just introduce it, and Dr. Barfield will finish on that. So here is. Can you all see it, Moderator February?
Yes, of course, Ms. Nola.
Perfect, perfect. All right. So let me go to the, I'll move this and go to the slideshow. All right. So can we move? Perfect. Here we go. So we're looking at, again, HIV in pregnancy. We're just going to run through a couple of these since, again, most of them were discussed earlier by the other speakers. And I must say that I really enjoyed the topics for this presentation, especially just now hearing about jackfruit. The jackfruit is one of my favorite fruits. So hearing all the innovative ways that I can use it, I'm all for that. So here we are looking at, let me slide them. Yes, can I move this forward? All right. We already mentioned about HIV. We know that it depresses the immune system, can lead to AIDS. It's an opportunistic infection. You get cancers, other viral infections. You can become positive within 6 to 12 weeks after exposure. You get this fever, headache. But what's going on is that you're depressed in all your immune markers, right? This is where I want to get to. Because while HIV in America is significantly decreased with all our medications or in our safety precautions, all our information and education, there still remains in America a huge discrepancy among the ethnic or racial groups. I don't know how much of a discrepancy you have in Indonesia, but America is very, very diverse in terms of the population. The population of African Americans, Hispanic, whites, Asian, multiracial, or Native African or Native American Indians or Alaska Natives. As you can see from the chart, those who are Black or African Americans still has a disproportionately higher risk for HIV than any other group. So whereas we may not have a huge population, and we still do, really, of HIV positive cases, those who are HIV positive, the racial or ethnic group makes a difference. We talked about the perinatal transmission and the fact that, you know, we just mentioned from the position statement that you'd rather have a cesarean section depending on her viral load and the risk for breastfeeding. I'm now going to hand over to Dr. Barfield. Dr. Barfield, I'll move the slides while you talk about the situation.
Okay. Thank you for having us here. I really appreciate the invitation that Nola, she dragged me here, and I wanted to be a part of this discussion because it is very important. And the common thread that I've heard all throughout the different presentations is still about stigma related to HIV, which is quite prevalent as well in the United States. So we want to prevent transfer of HIV to the unborn fetus. And we know that the transmission rate is lowered when we introduce AZT as part of the treatment regimen, and it lowers from 25% to 8%. Okay, especially the rates are even more lowered when we use combined antiretroviral therapy during pregnancy, because it lowers the risk to 1 to 2%. Okay, if the viral loads are at less than 1,000 copies or undetectable. So we want, hopefully women will come in early for prenatal care. And I would even go so far as to say all women should know their HIV status even before getting pregnant. So when she plans a pregnancy, hopefully we can counsel her about, you know, HIV risk, HIV high-risk behavior, high-risk behaviors, and notify her that she will be tested in pregnancy. So if a woman is HIV positive during pregnancy, we want to start antiretroviral therapy as soon as possible, because we want to prevent this perinatal transmission to the fetus. So the World Health Organization recommends lifelong antiretroviral therapy or prophylaxis where HIV is common. And in the United States, breastfeeding is prohibited, regardless of how well the mother adheres to her HIV medications. We prohibit breastfeeding in this country. Where the World Health Organization recommends that women living with HIV should be on lifelong combined antiretroviral therapies to reduce breastfeeding transmission. So where breastfeeding is common in certain countries for women who live with HIV, mothers and infants who are not affected, or if their status is unknown, they are allowing to breastfeed for at least 6 months while taking combined antiretroviral therapies. Next slide, please. So how do we want to counsel the patient? Before the opt-out approach, we used to have women sign these, do pre-counseling, letting her know about what the HIV test is and what those results may be, and they would have to sign a consent, then get tested and do post-testing. Now, as my colleague Nola has mentioned, we do an opt-out approach where clients, we do all the blood work together unless she declines testing. But they still need to know that they're being tested for HIV. So we still need to discuss HIV prevention, transmission, and testing with the woman. We want to also make sure she understands what risk reduction is and the medical and legal consequences of HIV negative or positive status. Give her plenty of an emotional support. When you are disclosing the test results to a woman, that visit should take some time, where you can spend time with the woman and really discuss all of these things with her and give the emotional support that she needs. So again, testing will be done as routine, part of the prenatal panel, where we do a whole bunch of different blood work, and also she's tested again in the 3rd trimester. All right, so we look at viral loads. This is how we monitor the HIV disease, and if the viral loads are increased more than 1,000 copies, maybe due to if she didn't have any treatment or poor medication adherence or resistance to her antiretroviral therapy, or there wasn't enough time to obtain suppression, we need to explain all of this to the woman. This will determine which mode she will deliver, if she will have a normal delivery or a cesarean section, and we need to discuss the risk and benefits with both modes of delivery. Also, part of her care will be an interdisciplinary care with infectious disease, with a perinatologist who specializes in seeing women with high-risk pregnancies. They don't deliver, but they do give recommendations and monitor a woman during her high-risk pregnancy. So she would definitely need interdisciplinary care during the pregnancy. Next slide, please. So again, we give these results in person to discuss all this, the implications and the risk for vertical and horizontal transmission. Also, partner notification is a big thing as well. That is reportable to the state. We have to disclose that patient's diagnosis so that they can get in touch, give a list of all the partners and get in touch with the partners to notify them as well. And again, the antiretroviral therapy should be initiated as soon as possible throughout the pregnancy. And I just mentioned about infectious disease involvement. We will monitor her for side effects of the medications. Her lab work, we will monitor, of course, a complete blood count, a metabolic panel, her viral loads and CD4 count, any resistance to the antiretroviral therapies. Hepatitis A, IgG for women with hepatitis B, and she was unvaccinated for hepatitis A. And we want to get a hepatitis B surface antigen and viral load and a hepatitis C virus antibody. Immunizations that can be offered to this woman during her pregnancy is hepatitis B virus, the pneumococcal vaccine, and influenza type B viral vaccination. So we want to also include, just with the last talk, the last presenter talked a lot about nutrition, which is very important in pregnancy, rest, and strict medication adherence so she doesn't develop resistance to the HIV medications, and of course, condom use. That's the best protection we have. So again, we already mentioned about the opt-out approach. So we recommend all women to be tested regardless of their behavioral risk factors, and inform them that HIV testing will be done. So she opts out. She has the choice, as Nola said, that we have to respect their choices. So testing is done before pregnancy. The optimal time is early pregnancy, and we repeat in the 3rd trimester before 36 weeks. Okay. With initial negative HIV antibody tests who are at high risk for acquiring HIV infection, and HIV incidence in pregnant women, and at least 1 per 1,000 per year. And these high-risk populations of pregnant women who are incarcerated with signs and symptoms of acute HIV disease. And we monitor the HIV disease. Yes,
Ms. Starfield, forgive me.
Yes.
Forgive me. You only have 5 minutes left.
Okay.
Thank you.
And this
Thank you.
presentation. Thank you.
Thank you. So we monitor her viral loads during pregnancy while she's taking antiretroviral therapies during the first prenatal visit and 2 to 4 weeks after initiating or changing regimens. Next slide, please. Another big thing is if if the mother does not get tested during pregnancy or her status is unknown, we do offer rapid HIV testing. When she comes on labor and delivery, she will get those results the same day. And this will also aid in how we decide how she will deliver. So again, if she has a high viral load above 1,000 copies, then she needs to be offered with a cesarean birth. Rupture membranes have no bearing on how she will deliver. We do not use any invasive procedures like fetal scalp electrodes or operative vaginal deliveries with use of forceps and vacuums, which can increase the risk of transmitting HIV to the neonate. So neonates usually are asymptomatic and they are presumed to be HIV positive because of the maternal antibodies that is present in the fetus. We do bathe the baby as soon as possible within 12 hours to reduce the risk of transmission, and newborns are treated for 6 weeks with AZT, and hopefully she had adequate antepartum treatment. And additional antiretroviral therapy is needed for high-risk newborns with inadequate antepartum therapy. We do a HIV DNA PCR testing done when the baby is born at 1 month and 4 months of age, and to continue monitoring the newborn closely until 18 months old. Thank you so much.
We thank you for your time and for having us here, Mr. Febri and Miss Desi. Thank you, Miss Desi and Miss Nurimati for including us. But we need to go now and go to sleep.
Sorry. Okay. Thank you very much, Miss Nola and Miss Barfield.
Thank you.
Do you want to skip any question related to your materials?
Sure. Do you have any questions?
Sooner you go to sleep.
Yes.
Okay.
Any questions for us before we go?
Okay. Okay. Actually, we are going to go to the question and answer session, and I'd like to have 3 questions, and maybe we can start with first speaker. And the question is from Miss Nurul. First speaker, Miss Wan Rohani. Panitia, tolong bisa diberikan highlight untuk Miss Rohani.
Okay, Assalamualaikum.
Miss Rohani, Waalaikumsalam, Miss Rohani. Maybe you can answer the question from Nurul. Nurul is a lecturer from Pharmacy Department of Poltekkes Kemenkes Medan, Miss, and she is working and fighting for PhD program in University of Gadjah Mada in Indonesia. So maybe you can help her to answer the question.
Ms. Nurul. Actually, I have a couple of questions that raised in the chat box just now, so I take note all the questions. Can I answer all those questions? Because I need to rush to another program at the university. So one question regarding how many percent the person develop this active TB. Actually, it's around 10% who are in the dormant state or latent TB to develop as active TB. And there's also cases with the recurrent TB as well. So if talk about recurrent, there's more than one episode of the relapse stage with the previous strain. And that's the main challenge actually in controlling this TB epidemic in the national control program. So either it is through the endogenous reactivation or exogenous infection with the new episodes of TB. So it's based on the isolate of the TB itself, whether it's come from the same strain of TB or might be coming from a new strain. So if it is identical isolate, then it's a relapse. So it is potential to develop as a recurrent or relapse to other patients as well. And it also depends on the medications and also the immune status. So basically when I talk about the immune response, so that's the main challenge or the major factors that affecting the body response to any infection, including the Mycobacterium tuberculosis as well as the virus like HIV. So that's the main, that's for the first questions. So the second one is regarding the HIV and TB, because this coming from the nursing student. I'm not the nurse, but I try to answer according to my background in biomedical sciences, where these two kind of infection between virus and also bacteria, or related to your immune status. So there will be a mutual genetic entities as well, where they share the same epitopes, when and it influence your suppress your immune system as well. That's why the infection will become higher, or the immune because of the immune status has been depressed due to this co-infection. So there's a possibility where the management of this patient between HIV and also TB should be looked at the signs and symptoms according to the immune status as well. And the third one regarding the treatment of HIV, I'm not I'm not from the medicine, I'm not the medical doctors, but for the treatment, theoretically for treatment for HIV, actually they give the antiretroviral drugs or medicine to stop this virus replicate in the body. So this allows your immune system to repair itself. That is theoretically. Okay, and then the fourth one actually regarding the CCR5 that I just mentioned in the slide just now as a co-receptor. So what happened in the HIV infection that has been raised by the nursing student as well. So actually, yes, it gives the same reaction where this CCR5 is a co-receptor. It will be used by this macrophage and involved in this viral transmission. And it will involve a lot of other chemokines as well, like MRP, MCP, and this at the end it will suppress or reduce the CMP production. So basically, the role is to suppress the T lymphocyte regulatory by reduce the CM production. And the fifth one is, I think, is regarding the genetic microbe and host. Is it which one is more priority, whether to check the genetic variants on the microbes or genetic variant on the host, which is the human? Actually, both. Both are important. And that's why we need those profile in the transcriptomic profiling to match which the gene expression for the microbes with the gene expression from the host. We can match in terms of molecular mechanism. So by having these two profile, we can identify which gene been regulated by another gene from the bacteria itself. Okay, so that's how we able to identify the most potential gene that involved in the disease pathogenesis and come up with the potential biomarkers. So meaning that host profile, genetic profile is very crucial to understand the mechanism underlying for this interaction between host and the bacteria itself. And as well, the virus change into different structure with different strain. Of course, this is the most challenging to come up with this specific treatment. That's why every single strain, like COVID-19, we have many strains. So that's why we need to see the profile itself, then we can provide different vaccination. So that's why we come out with different drug treatment according to the profile. that been projected by the virus itself or the host defense itself. And then I go very quickly, sorry. Hopefully the information is there. And this one asked me about the TB treatment. Is there any TB treatment according to the personalized medicine? Actually, as far as I know, not yet, because the process is very long. As what I just discussed this morning regarding the identifications of the gene, okay, or the SNP or at the haplotype level, based on the GWAS, and then after that, there's another step that we need to correlate with the transcriptomic profiling that was just introduced just now, differentially expressed gene. Okay, then we go to the functional analysis, either in vivo or in vitro. In vivo, meaning that the study will be conducted in animals, and in vitro on the cell line. So we can, knock out the cell, the gene itself, or we can silence the gene. So that's how we know the functional or the mechanism of the gene. Then we go to the final stage, to the clinical trial. Okay, this is the most challenging process where you need to test these drugs according to the personalized medicine to the human. So this would take I think ages, to come up with the potential biomarkers. But this profiling is very crucial by having the mechanism molecular behind it. Okay, that's it. I think that's more related to my field.
Okay, thank you, Miss
Okay.
Rohani. If you still have a time, I still have one question for you. Yeah. Anyway, I always ask the speakers about this same question, Miss.
I need to
Yeah.
go Pak February because
Okay.
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 So I'll catch you up later.
Okay,
Okay.
okay.
I welcome any more questions. Okay.
Okay.
Keep in touch.
Thank you,
Okay.
thank you.
Assalamualaikum
Thank you, Miss
warahmatullahi
Wan Rohani. Okay. Miss Rohani want to continue her activity in the university, so we continue to the audience. Here is Miss Emi Inaya. Yeah. Panitia, Miss Latisha and Miss Nola is still here. Panitia, Bu Nola dan Bu Latisha Barfield, apakah masih di sini?
Okay. Thank you, Mr. Febri. I want to ask to Mr. Mansur.
Yeah, yeah. Okay, Miss Amy, continue with your question.
Assalamualaikum. Good afternoon, Mr. Mansur.
Waalaikumsalam. Kok aku
Okay.
juga ditanya ya?
I am a lecturer from Department of Nutrition, Medan Health Polytechnic. And my question is, as a researcher, how your organization or your education institution develop food innovation to strengthening the body's immune system against HIV and TB infection. And second question, what promising food-based strategies are being developed to prevent HIV and TB in high-risk population, especially in Indonesia? We almost or always get HIV and TB infection in our citizen. Maybe we can copy your strategy, especially in food innovation, to uh, decrease the risk. Thank you, Mr. Mansur. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih, thanks for the question. Sebetulnya nggak ada yang spesifik. It's not, there's no specific strategy, okay? But as mentioned just now, most important, that I mentioned in my slide, most important is who's our targeting group. Okay. In my case over here, in our case over here, normally we are talking about mothers and children, but we also have several other population category. Yeah, like maybe for those maybe what I can maybe bisexual, sexual, or any other category of that highly potential to get this disease. Okay, so as mentioned, normally we have several category of stages. Okay, to maybe protect ourselves. Okay, the most maybe for at the beginning stage, talk about awareness. Awareness meaning that yeah, maybe based on our what religious, okay, or maybe yeah, maybe based on our knowledge, okay, we know that all these disease normally is still dangerous, and there's no what cure for 100% for this particular disease. So I think the most the awareness and maybe yeah, talking about the good quality of a lifestyle. Okay, this the most we need to maybe take a the good approach on this. But accidentally, or maybe we also don't know. Okay, and then come to second stage whereby we already diagnosed, okay, with this disease. So the most important, we must take a medicine. Okay, this already proved that normally we try to deactivate the 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 virus. Okay, the virus. But at the same time, we must have a supportive what task, okay, which is the good nutrition, okay, therapy. Okay, so talking about this patient, normally they are simple one. Normally they are really exposed to the because they are like low in what the antibody. Okay, so most probably they are really simply get the although maybe not dangerous or maybe it's not considered yeah, dangerous disease. Okay, so so other than the medicine, okay, we also need to support them with the good nutrition. Okay, so good nutrition meaning that most, as mentioned, they are lack in nutrient. Okay, especially for give the energy. Okay, like protein, carbohydrates, so on. Meaning that we must give them the balanced food. Okay, and at the same time, they are also lacking in micronutrient. So we need to identify, especially ingredient. Okay, surround us. Okay, as I mentioned in our slide, most of the ingredient normally available. Okay, like the soybean, maybe the green vegetables. Okay, there's a lot. Then they will supply us a lot of mineral and vitamin. So unfortunately, especially children, okay, even teenagers also, they don't like to eat the fresh vegetable in form of nature, okay, natural form. So we need to transform it into some other form whereby they do not see the, the real form of the vegetables, yeah, like what we did for the maybe innovative food, okay, by transform into noodles, okay, incorporate in noodles or maybe some other food products, okay. But bear in mind, we must identify, okay, from that particular location of our patient, what the most common food, okay, that they are consumed, okay. Worried that we develop food product, but maybe unknown for them or maybe not familiar. So tendency for them to try the product or to consume the product is very, very low. So it's also need to do some strategy, okay, whereby we need to identify the food product and then identify what the most ingredient available, okay, or maybe not utilized, okay. So they also involve later on the cost in terms of your production, okay, and then we try to develop product and then do like normal innovative or maybe innovative step of processing. Okay, we must create formulation and then do sensory, okay, to choose because like different person maybe they have different preference of food. Okay, so although we know that this kind of ingredient contain high in certain percentage of nutrient, okay, but unfortunately maybe they're not like to consume this. So maybe we have another backup or maybe choice of other ingredient. Okay, but for children normally you must produce the most suitable product that they really look or like, yeah, to eaten, and then must have a good attractive in terms of appearance, especially color, and then must have a good taste. Okay, this normally what we go through for the innovative food processing. Another one, we also need to consider that we not consume the product just in the fresh form. We also need to maybe put in some dilution, okay, a period of study whereby the product quality still remain in good quality. Okay, and then of course we are talking about maybe the good packaging, okay, because talk about maybe delivery system later on, okay, especially for the remote area whereby maybe the certain cases maybe over there quite high. So we must put the convenient food product and then easier to consume, easier to prepare, okay, so make the product, meaning that most acceptable by the community or target group. This for the question, which one? I also forgotten lah. Which one? The second or first?
Excuse me, Mr. Mansur.
Yeah. I had Ibu Ernie just now. They give 2 questions. So I also
Yeah.
The second question.
Yeah.
The second question about what promising food-based strategies are being developed to prevent HIV and TB in high-risk population,
Okay, thank you.
especially in
Okay.
Malaysia.
Okay. The food promising, yeah. Okay, there's no very no specific food actually. Okay. Because based on our experience, normally we already do some review on the ingredient, especially lah. Okay, on the ingredient, because the most important when talk about passion, okay, we must give the good nutrient supply, okay, available in our ingredient. Okay, so we already put a list, and then we also need to identify what the most suitable food product need to develop. Okay, and then maybe we have a choice. We can't put maybe for only one sample. Okay, normally we have several, maybe 2 or 3 types of foods, and with a several type of ingredient, because the preference might be different from ours, okay, as a researcher, as compared to our target group. So let them choose which one they prefer, and then later on might be we try still to need to do what might be some modification, okay, because when talk about nutrient or micronutrient, there are several percentage, the minimum requirement. So we need to fix this first, okay, and then we maybe increase it later on. Okay, we not really focus on the. Of course, when talk about product development, the acceptability is most important, because no point if the product is very high in nutrient, but later on nobody want to use it. Okay, so we are trying to to produce the product with the high or maybe with most acceptable, okay, by the panel, and maybe we try to increase based on the requirement in terms of the nutrient. Okay, this normally our practice lah. Okay, may I answer your question, Ibu Emmy?
Ibu Emmy, do you have any response for speaker?
Alah, silent.
Ibu Emmy.
Dibuka. Nggak kedengaran.
Still mute, Ibu Emmy.
Can I hear? Yeah.
Okay. Thank you, Mr. Mansur. I think it's clear enough.
Okay.
Thank you. You make my insight better than before.
Okay.
Especially about food innovation. Thank you very much.
Okay, thank you very much.
Thank you very much, Mr. Mansur, to answer these questions. And now, everyone, ladies and gentlemen, we have still several questions from all participants, but sorry, time is over because we have to continue to the next session or our presentation. So we already have uh, like 5 questions and have been answered by the speaker. So thank you. Okay, ladies and gentlemen, we finally come to the end of this session. And before I close this session, I would like to take a conclusion from what the speaker has presented. First, addressing HIV AIDS in pregnancy requires a multifaceted and comprehensive approach to safeguard the health of both mother and the unborn child through advancement in medical intervention and prenatal care. It is possible to significantly to reduce the risk of mother to child transmission. And second is by addressing specific nutritional needs and leveraging the benefits of functional food, healthcare practitioner can contribute to a holistic approach in managing HIV as well as TB, ultimately enhancing the well-being and resilience of those facing these health challenges. And the last conclusion is the exploration of haplotype SNP marker in tuberculosis from genetic perspective offers valuable insight into a complex genetic landscape of susceptibility and diversity associated with the disease. So it's time to the Medan Health Polytechnic or Poltekkes Medan to carry out a research using a genetic approach to realize the institution mission, namely to compete with other institutions at global level. So, and finally, I'd like to thank you to the all speaker here, Mr. Mansur, and then uh, Miss Hola and Miss Wan Rohani. I'd like to thank to the all speaker for the informative and interesting presentation and all the participants for very active participation. And finally, we give applause for the all speakers and for you as a participation. Thank you, and I give it back to the Master of Ceremony. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much.
Waalaikumsalam
Assalamualaikum.
warahmatullahi wabarakatuh. Okay, thanks, Mr. Febri. Happy attendees. The second session have been completed. Let's give applause to all speakers and moderators. Okay, now, ladies and gentlemen, our presentation have been implemented well. First session and second session. Finally, we get to the last session in this event, that is closing. As the master ceremony, thanks to all speakers, moderators, and the conference committees, and the audience entirely. We hope this event can be useful for us, especially to controlling HIV/AIDS and tuberculosis in mother and children. If in guiding this event, I made mistakes, please forgive me. Thanks for Allah Subhanahu wa Ta'ala and all of you. I give pantun, Pangeran berlayar sampai ke Birun, menaiki rakit sampai ke Pulau Putri. To participant, thanks for your attention. Keep the spirit and stay healthy. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and see you next time. Next, we inform for oral presentation participants. We will rejoin the Zoom meeting at 14. Okay. For committees, any? Okay. Okay. That's it up. Thank you for your attention.
Untuk semua peserta oral presentation, silakan masuk ke breakout room sesuai dengan moderatornya. Bapak Ibu yang oral presentasi, silakan masuk ke breakout room yang sudah disesuaikan nama-namanya. Terima kasih. Izin Bapak Ibu, untuk semua peserta yang oral presentasi, silakan masuk ke ruang berdasarkan moderatornya. Sudah bisa mengklik breakout room. Breakout room, kemudian memilih nama moderator. Silakan Bapak Ibu yang oral presentasi. Bagi yang tidak oral presentasi, silakan memilih room mana saja untuk menjadi peserta. Silakan Bapak Ibu. Silakan Bapak Ibu join ke room sesuai dengan nama-nama moderator peserta oral presentasi.